good morning to you. A very good morning to you, our esteemed dignitaries, distinguished guests, ladies and gentlemen. On behalf of the Ministry of Health, it is our distinct pleasure to welcome all of you to this Cardinal Cancer Forum, anchored on the theme, Transforming Cancer Care in Ghana, a roadmap for sustainable prevention, early detection, equitable treatment, and resilient systems. Ladies and gentlemen, here in this auditorium this morning, I want to say that we have the brains from academia, we have experts, we have our policy makers, people from civil society organizations, and our development partners who are going to ensure that within these 2 days, we cross all T's and dot all I's so that we will arrive at our set objective. And so once again, on behalf of the organizers, I want to welcome all of you and to tell you that your presence here this morning is highly appreciated. My name is Mabel Addo, the Deputy Public Relations Officer of the Ministry of Health, and I'm doing this work.
So I'm Lawrence Oseji, I'm pediatric hematology oncologist from the beautiful city of Kumasi, the best city in Ghana. Food is cheap. You can find anything there. And I'm a talkative, so they called me to come and talk, all right? So we'll be going through the program lineup. Please, you can scan the QR code that's displayed and you can see it. So let's invite right away Madame Felicity Jansa to give us the opening prayer before we forget about God.
Okay, shall we pray? Almighty, everlasting God, we thank you this morning. We thank you for everything you've done for us. We thank you for the life. We thank you for the traveling mercies you granted those far and then also near. Father, this day we pray committing this program into your care. We pray that let this program be a success. Father, whatever discussion that will go on here, we pray that let it come to pass, let it be accomplished. Father, any deliberations, we pray that may you be the chair of those deliberations. Father, let us also help us to put Ghana first. Help us to also bring out our best so that we can help the country in the journey through the cancer care in Ghana. In Jesus' name we pray with thanksgiving. Amen.
Thank you so much, Madam Felicity. Ladies and gentlemen, I would want to acknowledge here the presence of our partners and some key personalities who in the course of this program we would introduce. But at this point, it is time for us to receive our welcome address. And it is an honor for me to call on the administrative head of the Ministry of Health, Mr. Desmond Boateng, the Chief Director of the Ministry of Health. Let's welcome him with a round of applause.
MC, thank you very much. Sometimes when I get scared when I have MCs introducing me. And there was a time that one of them said, I was a sector minister. So when I took the mic, I had to plead and beg that my job is at stake. Thank you very much once again, MC. Reps of all ministers for health, finance, and communication, the heads of agencies here present, health sector development partners, directors within the health sector, friends from research and academic institutions, friends from the media, distinguished ladies and gentlemen. It is a great honor on behalf of the Ministry of Health to welcome you all to this important National Cancer Forum. We are gathered here under the theme Transforming Cancer Care in Ghana, a roadmap for sustainable prevention, early detection, equitable treatment, and resilient systems. A theme that captures our collective resolve to transform cancer care for every Ghanaian. Dr. Chairman, ladies and gentlemen, cancer has become one of the most significant public health challenges globally, and Ghana is not excluded. The increasing incidence of breast, cervical, prostate, and liver cancers have placed a growing burden on our health systems, families, and communities. While many institutions, ranging from teaching hospitals and research centers to non-governmental organizations and private facilities, have made commendable efforts to address this challenge, these interventions have often been fragmented, lacking a unified framework for coordination and governance. Recognizing these challenges, the Ministry of Health, leveraging its mandate, has over the years taken deliberate steps to strengthen the policy and strategic landscape for health in Ghana. We have developed and implemented a suite of forward-looking policies and strategies to bridge these gaps and ensure no one is left behind. Key among them include the following: the revised National Health Policy 2020, which sets a clear vision for a healthy and productive population for national development. Ghana's Universal Health Coverage Roadmap, that's 2020 to 2030, which also outlines our commitment to ensuring that all citizens have access to high-quality, essential health services without financial hardships. 3, the National Non-Communicable Diseases Policy and Strategy 2022, which offer a comprehensive framework for preventing, early detection, and managing NCDs, including cancer. These are supported by other sectoral policies and guidelines that strengthen our efforts in health promotion, screening, treatment, and palliative care. Ladies and gentlemen, our commitment as a government is further demonstrated through innovative financing mechanisms and strategic initiatives. The Ghana Medical Trust Fund has been established to mobilize resources for critical health interventions. The non-capping of the National Health Insurance Fund ensures sustainable financing for health services, including cancer care. Furthermore, our quest to introduce free primary health care initiative guarantees access to essential health services, including cancer screening and early detection for all citizens. These policies and initiatives are not only national priorities, but are also aligned with global efforts to achieve universal health coverage and the Sustainable Development Goals. They reflect our determination to enhance prevention, promote early detection, and ensure equitable access to screening and treatment for cancer and other non-communicable diseases. Ladies and gentlemen, today's forum marks a pivotal moment for Ghana. It brings together a diverse group of stakeholders, government officials, health professionals, academia, civil society, patient groups, and private sector partners. Over the next 2 days, we will engage in meaningful dialogue, share experiences, and collaborate towards the development of a national cancer control framework and a revised 5-year cancer strategy that's from 2026 to 2030. We aim to harmonize priorities, foster collaboration, and chart a sustainable path for cancer prevention and control. The agenda before us is both ambitious and necessary, as we will seek to address key issues such as equitable access to quality cancer services, resource mobilization, multi-sectorial partnership, and the integration of data and innovation into patient-centered care. We will also listen to the voices of patients and survivors whose experiences remind us of the urgency and humanity of our mission. Your expertise, commitment, and partnership are vital to the success of this endeavor. Let us seize this opportunity to build a future where every Ghanaian has access to quality and timely cancer care. I encourage you all to participate actively, share your insights for national response that is coordinated, inclusive, and sustainable. Dr. Chairman, ladies and gentlemen, as I conclude, permit me to say a special appreciation to our development partners for their financial support. Once again, I warmly welcome you all to the National Cancer Forum. Let us make these 2 days count for the future of cancer care in Ghana. Thank you very much for your attention.
We move on with the program. As the Chief Director said, timely. Cancer is time. It does not wait for you. So maybe about 300 years ago, humanity was afflicted by a certain pestilence. Many people did not know what was happening. They tried on a certain land elsewhere to do many things, including hanging crosses around the neck of people who seem to be dying from this pestilence. Others will come with a swelling which seems to be growing. One of them, experts then described them as the swelling grew, the sufferers became leaner. And they tried everything just until about 100 years ago, when serendipity and other innovations gave us solutions. This land was somewhere on earth. Let's see, do you think this land, where I speak of, belongs to the high-income setting or the low-income setting? Low-income or high-income? Why do you think this scenario would happen? Many people will say low-income, but 300 years ago, that was exactly what is happening in the high-income setting. But with partnership, with cooperation, dedication, specific funding, then cancer became known, and then there was a solution to it. So we are here today to discuss all those partnerships, and we acknowledge our partners once again. But let me take the opportunity, because I can see my chief executive, and I know I'm troublesome. One day, if he sacks me, I hope that Ministry of Health will accept me. And so I would want to introduce the technical advisor to the minister who has just arrived in our midst, Dr. Kokoa Awona, ladies and gentlemen. And then go on to sort of continue, for them to see me so that when I get sacked, they accept me. Director for DCD, Ministry of Health, Dr. Hafiz Adams. All our partners are welcome: WHO, Pfizer, Roche, Chai, World Child Cancer, and all the others will be introduced as we go on. But now, let me invite my friend and brother who heads the medical and dental affairs of the Ministry of Health, Dr. Ernest Kunedu Esiedu, to please come and introduce our chairman.
Thank you very much, Dr. Osei-Tutu. So, Chief Director of the Ministry of Health, Technical Advisor to the Minister for Health, representatives of other ministries who are here, the various heads of agencies of the Ministry of Health, and other departments and agencies who are here, our development partners, invited participants, distinguished ladies and gentlemen, all media and press present. I am pleased and humbled and have this singular honor to introduce our chairman for this important program on the theme, Transforming Cancer Care in Ghana, a roadmap for sustainable prevention, early detection, equitable treatment, and resilient systems. Our chairman is an accomplished medical practitioner and has had a distinguished career nationally and internationally. Nationally, he rose through the ranks of our health system to the very top position of Director of Medical Services up until 1997 as a relatively young age. Before that, he was head of a hospital, a district director of health service, a deputy regional director, and the first director of policy planning, monitoring, and evaluation of the Ministry of Health. He left our shores in 1998 to join the World Health Organization in Geneva, where he was an assistant director general for 9 years, and then also the deputy director general of the WHO for another 10 years. He retired in 2017, returned home, and has been involved in many activities of the Ministry of Health. He was very instrumental in the development of the National Health Policy and the Universal Health Coverage Roadmap, and recently the Ministry's work on health security. He was the presidential coordinator during the COVID-19 crisis, and until very recently, the chairman of the University of Ghana Medical Center and also the National Vaccine Institute. He normally says he's retired, but he's not tired. I think you and I would know that the chairman general has been the chairman for a number of occasions. Distinguished ladies and gentlemen, please help me welcome Dr. Anefi Asamoah Bao.
Thank you, Ernest, for the kind introduction. Mr. Chief Director, I will not make the mistake of confusing you with the sector minister. I don't know whether you are taller or he's taller. The technical advisor to the minister, administrator of the Muhammad Cares, heads of agencies, colleagues from the Ministry of Health and other ministries, development partners, reps of CSOs, NGOs, friends from academia and research institutions, friends from the media, invited guests, distinguished ladies and gentlemen, dear colleagues and friends. Thank you very, very much for inviting me to chair this maiden National Cancer Forum. I'm honored and humbled. In my church, when you are invited to chair a function, it causes financial loss. In fact, you are expected to make the highest donation. So I'm very happy that this is not a church function. Praise the Lord. I wish to acknowledge 3 groups of people. First, allow me to salute the organizers and sponsors of this wonderful initiative of a national forum. One may argue that this is long overdue, but it's better late than never. Secondly, we must all applaud our government, particularly the President, the Minister of Finance, and the leadership of the Ministry of Health for making non-communicable diseases and, for our purpose, cancer care sexy. To be fair, in recent years, and as highlighted by the Chief Director, cancer care has received increased attention, visibility, and some support. And we've all witnessed many positive developments on the cancer front. But it's also true that this is the first time government is making big money available to promote cancer care. The appeal of big money is that it allows us to think big, think outside the box, and to move away from selected projects towards universality. It is my prayer that this time around, we will not steal big, and monies meant for cancer care will go into cancer care. The third group I wish to recognize are the individuals, groups, organizations, and institutions that held the fort at the time when cancer care was not sexy. Some are in this room. Some have been very vocal advocates, but many have been working quietly without fanfare. Without you, we will not be here today. Ghana is grateful. They deserve an applause. This is the very first national forum, so it's historic. I learned many years ago that historic also means we'll make mistakes. So we welcome any suggestions that you may have for improving the organization and conduct of this summit. I have 2 suggestions. First, since cancer is a chronic condition, we should be emphasizing what I call the trinity of care. Anytime we talk about patients, we should also be talking about families and caregivers. So we should not just end with patients. It's patients, their families, and caregivers. And we must remember that what they need is not just medical care and financial assistance. They also need nutritional care, emotional and psychosocial, spiritual, and survivorship support. And we must remember that people's cultural, spiritual, and religious beliefs do shape their health-seeking behavior. My second plea is about prevention. We cannot treat ourselves out of the cancer crisis. We must be aggressive about prevention. And we need multisectorial action to work on the determinants of cancer in Ghana. Your Excellencies, a few years ago, as a nation, we were confronted with the COVID-19 crisis. We must learn from it. I'm not proposing we offer people free water and electricity and later charge them for it. One of the positive aspects of our response was how the whole of society was mobilized for COVID. We need to do the same for cancer care. Distinguished ladies and gentlemen, with the expertise wisdom and the many years of experience assembled in this room, I have no doubt that we'll have a very successful summit. Thank you for allowing me to be part of this historic summit. Thank you. God bless you. Assalamu alaikum.
All right, thank you so much, Senior, for that. And it captures everything well. Just a couple of years ago, I was privileged to have met with a mom whose son, through the benevolence of many, many, many organizations, including trailblazers like Professor Lorna Aworena. Let's clap for her, who has led the revolution of childhood cancer care in Ghana. That it was possible that right in the middle of Ghana in Kumasi, a child from nowhere could access leukemia treatment and was alive 6 years after diagnosis. And I was so excited that, wow, I met you about 6 years ago. It's fantastic to see you again. And all smiles, and the mom broke down in tears. She was crying. I thought it was tears of joy. So she said, Doc, she said it in Twi, which is much better, but let me try in English. I have my son, but I've lost my husband. I've lost my house. I've lost my job. I've lost friends. I owe so much that when they see me coming, they run away. So beyond curing the disease, there's rehabilitation. We need to support not the patient alone, but their families. And we have so many partners helping us to do this. And so we shall invite our partners to give us brief remarks as we start off with my favorite organization, City Cancer Challenge, CCAN, who have been leading a revolutionary, holistic approach to cancer care in Kumasi. I know Accra is jealous, but it's fine. We should lead a little bit in one way or the other. And there are different models across the different sectors of cancer care, from pediatrics to adult to survivorship and palliative care. City Cancer Challenge, CCAN. I know the first name is Sophie.
Yes, I don't think Accra should be jealous. We are here because Accra is part of the journey. So I'm Sophie Busman Kemjo, Director for Africa and Europe at City Cancer Challenge. Honorables, distinguished leaders, colleagues, partners, it's really a moment here to acknowledge the leadership of the Ministry of Health in guiding this national dialogue. This is Ghana's moment, Ghana's leadership, and Ghana's vision for advancing equitable cancer care that bring us all together. And as our moderator mentioned, we are standing by the ministry, Ghana, to make this an actionable moment, historical moment, because we have all known how much this troubled time is also an advantage. It's the positive side is that it's bringing us really together here today to address our needs, and the ministry knows better than anyone what are those needs, and we as partners are standing by to support. Our journey in Ghana began back in 2018. That is a lot of years. So, and thank you, Lawrence, for mentioning, we have been by the Kumasi because the journey started in Kumasi, but always from day one to scale up at the national level. And today it is happening because the ministry has been taking the full leadership of the initiative, and as we speak, we'll be also forming the governance of the initiative from the ministries to make sure that whatever is being designed, implemented in Kumasi is feeding the national agenda and strategy, and also bridging it with everything that needs to be addressed for cancer care in the country. We have also been partnering with GIZ on this journey. So today we are here, as you can see on the logos, GIZ and CCAN are working together to make sure that we bring our track records of implementation of stakeholder engagement in cancer care in Ghana together, because when you go alone, you go slower. When you go as a team, you go faster. And this is really why we're here. We're mentioning GIZ, but of course, in the course of our work, each of the organizations you're seeing listed here, be it Roche, be it Pfizer, be it World Child Cancer, JPIGO, CHAI, and the WHO are organizations we're working with at SICAN, because we really believe in the multi-stakeholder approach to tackling challenges, because ministry alone cannot do it. The partners cannot come and do it on behalf of the ministry. And of course, we didn't mention that the civil society also, through the numerous NGOs that are actually addressing patients and their caregivers, have to be in the room. And this is how our model has been to bring everyone together. So what does SICAN bring? We bring practical, city-informed experience to support the country in moving from plans to implementation, strengthening early diagnostics, quality services, and advancing national standards that translate into real improvement in patient care. So we're really committed with GIZ and other partners, not only for today's call, for the dialogue, but working alongside you. I think I have said it, but it's really important to mention that we're here to continue, and the mandate is from the ministry, which makes it even stronger, because we're not doing it our corner. We're making sure that everything that, as development partners, we're coming into the room, we are supporting what is being designed at the national level. So I would like to insist on two aspects that should guide this national dialogue, and that, as the chairman was introducing, is to actually be aligned behind the direction that the ministry is taking. This commitment is here, and Dr. Awona in the room, we have met him in Geneva last May to assure that we were committed together with GIZ to continue to work. So this is a journey. We're here in this room, but this conversation started with our strong commitment last in May, and today is really an honor to be here and to see it is happening, and that we're going to leverage each organization's strengths and find synergy to ensure that the optimal allocation of resource is happening through this partnership. So one common direction, no duplication. We are a lot of actors in cancer in the country, and this platform, from Kumasi to Accra. I see Dr. Rafa in the room, one of our champions from Kumasi, and many other of you. So we're all here to work together and make sure we're not duplicating. We're really supporting, and that this really should be our guiding principle for this conference and for this dialogue, from talk to action. And really with that, ladies and gentlemen, distinguished guests and honorables, leaders, we want to make sure we're here, and I will not take too long of the time. I think the message is really here. We are here for a long game. We are here, and we have proven that we can do things. We were in Kumasi all these years, and now we're in Accra, and we're looking forward to the roadmap from this dialogue to define together with the ministry what will be our next step in Ghana, how we can better support. Thank you very much, everyone.
Thank you so much, Sophie. Thank you so much. So as she said, they work together with other partners, and we have GIZ, if they want to make a few comments. Then we'll have Clinton Health Access Initiative, JPIGO, Roche, Pfizer, World Child Cancer, my favorite, other CSOs and WHO.
Thank you very much. Good morning to you all. Mr. Chair, distinguished ladies and gentlemen, all protocols observed. This is a great honor to be here today on behalf of the AYA Integrated Healthcare Initiative and to support the Ministry of Health in this important moment for Ghana's cancer response. The AYA Integrated Healthcare Initiative is a multi-donor, multi-stakeholder investment and partnership platform that strengthens the prevention and management of non-communicable diseases, including cancer. This brings together the public, private and philanthropic partners under government leadership to build joint sustainable and scalable health solutions to improve the access to prevention, screening, and treatment across the country. Through this new strategic partnership between GIZ and CCAN and under the leadership of the Ministry of Health, the AYA Integrated Healthcare Initiative seeks to include comprehensive cancer care. With our integrated approach, we are supporting the implementation of Ghana's national NCD strategy and to align with the National Cancer Care Roadmap. By focusing on the patients and strengthening integrated care pathways, Ghana can address underlying links between the conditions and ensure more holistic, effective, and sustainable health outcomes. We are proud to support the Ministry of Health in advancing this national effort towards better outcomes for the Ghanaian. We are here to provide support together with all the listed partners that we see around the table today. We are looking forward to the outcomes of this program and to the next steps in how we can move cancer care forward for Ghana. Thank you very much for your attention.
Thank you so much. And then I have my friends, Chai, Clinton Health Access Initiative. Coffee.
Good morning. Mr. Chair, please permit me to stand on established protocols. So on behalf of the country director and the entire Clinton Health Access Ghana team, we want to commend the Ministry of Health and its partners for organizing this National Cancer Forum. It's always refreshing and energizing to be in the same room or space where we are all united behind one mission, which is to improve cancer care in Ghana. Over the past few years, Chai's work in Ghana has been deeply centered around improving access to cancer medicines and strengthening the systems that make effective treatment possible. So working hand in hand with the ministry and other teaching hospitals, we've supported Ghana's first national mobility-based forecast and quantification exercise for oncology medicines. This was a very critical step. For the first time, Ghana has a clear data-driven picture of how many patients are being treated, what medicines are needed, and how to plan procurement in a way that is efficient and sustainable. Following this, we have also been working with the ministry to establish a coordinated procurement system for oncology medicines, moving away from the fragmented facility by facility purchasing to a more strategic pooled approach. This, we believe, will lead to a lot of savings. Beyond this, our work further strengthened, by Chai's global market shipping efforts, including the establishment of the Cancer Access Partnership program, where CAPLO negotiated lower prices with manufacturers, reducing the cost of quality assured oncology medicines by an average of about 60% compared to regular prices. But our ambition does not end with medicines. Cancer care requires a continuum, which includes screening, diagnosis, treatment, survivorship, and financing. And Ghana's momentum in these areas is very encouraging. As we look ahead, Chai is committed to supporting the ministry in several critical areas. The development of the new National Cancer Control Strategy, strengthening the National Cancer Registry, and exploring sustainable financing pathways are key areas that we are committed to supporting. Again, we are looking at working hand in hand with the Ghana Medical Trust Fund to improve access to medicines as well as infrastructure. We also see enormous potential to expand access to the treatment infrastructure, especially radiotherapy, drawing on lessons from the child-supported work in Kenya and then in Tanzania. So today our message is very simple. We are here as a committed partner, not as a short-term implementer, but as an organization ready to walk the long journey with you, strengthening systems, shaping markets, bringing global expertise, and helping Ghana achieve a future where cancer care is affordable, equitable, and then accessible to all. Thank you once again for the opportunity.
Thank you so much, Coffee. I'll invite my friend Parker from Chicago to also give us a brief remark.
Thank you very much, Lawrence. Dr. Chair, all protocols observed. Japago is an affiliate of Johns Hopkins University and has been a trusted global health partner for over 50 years, working in more than 45 countries, including Ghana, to enhance health outcomes through innovative, evidence-based interventions. Since 1978, Japago Ghana has collaborated with the Ministry of Health, Ghana Health Service, and other key stakeholders to implement high-impact programs in maternal, newborn, child health, adolescent health, family planning, reproductive health, women's cancers. We supported with the COVID interventions, including immunization, infection prevention, and then global health security. Currently, with the support of donors, including the US government, Pfizer Foundation, the Latter-day Saints Charities, and a planned collaboration with CHAI, Japago is supporting the Ministry of Health and the Ghana Health Service priorities to improve quality reproductive services in 10 regions, strengthening oxygen ecosystem, and improving access to early detection, diagnosis, and treatment of breast cancer in 3 regions. With funding from the Pfizer Foundation, Japago is partnering with MOH and the GHS on the Beat Breast Cancer Project, a transformational initiative aimed at reducing mortality among women with breast cancer through stage shifting, early diagnostics, and timely treatment. This partnership seeks to reduce the symptomatic period of breast cancer in Ghana from the current 12 months to less than 3 months by rooting the intervention in innovations, women-centered care, patient navigation pathways to saturate primary health care capacity for early detection by clinical breast examination, to institutionalize breast health awareness interventions in SBC platforms, and then also ensure timely diagnostics by decentralizing diagnostics at the secondary level and facilitate access to multimodality treatment. This aligns with WHO's Global Breast Cancer Initiative, which recommends the 60-60-80 approach. With support from MOH and the GHS, Japago aims to strive towards creating strong, innovative, and sustainable implementation modules integrated in the Ghana's health system and grounded in a women-centered approach to ensure respectful and responsive services for all women with breast cancer. This 3-year project is being implemented across 12 districts in Ashanti, Greater Accra, and the Northern Region. But specific to this meeting and why we are here, the Beat Breast Cancer Project, in partnership with MOH, has also planned various convenings, one of which is this, and we are excited to be part of this, with key stakeholders to facilitate structured engagements aimed at fostering collaborations, sharing best practices, and driving coordinated action for comprehensive breast health care in Ghana. As a project aiming at achieving the 60-60 approach targets, we work closely with the WHO GBCI and WHO Ghana Country Office, as well as other stakeholders, to ensure that we are able to bring context-specific interventions to achieve this. And we're excited to be part of this convening. Thank you.
Thank you, Fakoma. And I do not want to break the bond between the mom and the child. So forgive me, Rosh. Let me invite Punama from World Child Cancer. We've spoken about the central importance of the mom. Let's see, and bring in the child right now before we do Rosh, Pfizer, and other CSOs. Thank you.
Hello? Please, can you hear me? All right. Dr. Chair, all protocols observed. I'm honored to share the insights from World Child Cancer, as well as our expectations from the Ministry of Health. Before I start, I would like us to look back in time. In the year 2010, before World Child Cancer started operation in Ghana, Around that time, survival rate for childhood cancer was between 10 to 20%. There was only one pediatric oncologist who is here with us, and she's the World Child Cancer Overall Program Lead, Professor Lorna Aworena. There was only one treatment center, Kolebu Teaching Hospital. Abandonment rate was very high, and cost of treatment was also high. In 2010, World Child Cancer started operation in Ghana, and 15 years down the lane, through the collaboration with various colleges responsible for specialist training in Ghana. With that, I made the Ghana College of Physicians and Surgeons, the Ghana College of Pharmacists, and the Ghana College of Nurses and Midwives. Today, we can boast of 21 trained pediatric oncologists, of which 13 are Ghanaians and 8 from other sub-Saharan African countries. We have trained 50 pediatric oncology nurses, of which 46 are Ghanaians and 4 from other sub-Saharan African countries. We can also boast of 3 fully trained pediatric oncology pharmacists and 4 in training as well. In addition to this, we continue to support with the training in various aspects like radiology, nutrition, palliative care, early warning signs and symptoms, among others. With regards to support for families, we complement the efforts of government together with other partners to provide direct financial support which covers some aspects of diagnostics, treatment, and transportation. Again, we provide ready-to-use therapeutic foods for children in care. We also provide scholarships for survivors, and also we continue to provide emotional support through the Child Life Specialist. And I'm happy to say that through the collaboration with Ghana, University of Ghana, as well as University of Health and Allied Sciences and the Ministry of Health, we have launched the MSc Healthcare Play Therapy Program, which is yet to start hopefully next year. Again, on advocacy and awareness creation, we continue to engage various districts, regional and national stakeholders so that we can create more awareness on childhood cancer care. You all agree with me that childhood cancers are not preventable, neither are they also screenable, at least for most of them. So we do more with results or with regards to early warning signs and symptom screening. With advocacy, we also try to draw the government's attention so that more resources can be allocated to childhood cancer care. With regards to our expectations, we have lots of expectations from the ministry, but we will talk about a few. First is that the ministry should allocate more domestic resources, financial resources, to childhood cancer care. Again, with the expansion of shared care networks, bringing healthcare systems closer to the homes of children diagnosed with cancer and their families. At the moment, World Child Cancer supports about 6 shared care centers in around 6 to 7 regions. Regions like Upper West, Upper East, Oti, Western North, Savannah, Western Region, Ahafo Region, all these centers lack shared care centers. And we know that the government or the ministry can do that. Again, we also want to request that with regards to diagnostics capacity, the ministry should do more to expand diagnostic capacity because this is one of the main challenges. We know the ministry can do that. Why are we saying this? Because the ministry has showed us commitment. When you look at vaccine preventable diseases, under 5 mortality, the ministry has done a lot. So we are requesting that the same will and commitment should be transferred to childhood cancers. And I promise you it's going to be a litmus test for universal health coverage. Once again, thank you for your attention.
All right, thank you very much. And of course, my bias is very clear, okay? So I'm a child person. So Roche has also led the way in the support of treatment of child cancer with their innovative molecule supply and access. Roche.
Dr. Chair, permit me to stand on existing protocols. Ladies and gentlemen, as we gather today, united by a shared purpose to transform cancer care in Ghana through the development of a roadmap for sustainable prevention, early detection, equitable treatment, and resilient systems, we at Roche understand that achieving this requires a profound shift in perspective. We must move beyond viewing health as a necessary expense. The evidence is now unequivocal. Investing in early action and innovative medicines is a strategic economic investment for the future of any country. The rising burden of cancer, especially HER2-positive breast cancer, is not just a clinical crisis. It is eroding our demographic dividend and productivity capacity. The cost of delayed action in fragmented systems is staggering. Data from a recent WIFO publication across 7 African countries revealed the magnitude of this loss. Between 2017 and 2023, these 7 countries cumulatively lost approximately $10.3 billion in productivity just to HER2-positive breast cancer alone. This immense economic loss disproportionately affected the core of our workforce. 89% of these losses happen to women in their prime ages between the ages of 20 and 59. For every 100 breast cancer deaths in sub-Saharan Africa, roughly 210 children are orphaned, creating household instability and increased economic vulnerability. In Ghana, late-stage diagnosis remains our greatest cost in lives and in cities. We know that pre-treatment costs like biopsy and investigations are often the greatest financial obstacles, leading to critical delays. That's how some of our interventions include providing patient support in terms of diagnostics for breast cancer. To clarify further the economics of delayed action, let's view cancer and compare it to a car. Viewing cancer solely as a cost is just like seeing a light flashing on your car and saying just this is a warning. That is when you have the early detection and you don't take any action. You end up eventually spending more on the car. That is when you wait till it gets to the late stage. You don't only spend more to take care of your car or the patient, you also lose productivity losses the time you don't have your car available. The $10.3 billion burden presents a vast untapped opportunity for return on investment. Roche's partnership in Ghana has demonstrated this breakthrough. Since 2018, we have dramatically redefined HER2-positive breast cancer in the country, treating over 1,200 women with Herceptin on the National Health Insurance. We have shattered geographical barriers by expanding cancer treatment centers beyond Kolebu and Konfanochi teaching hospitals to Cape Coast, Ho, and Tamale teaching hospitals. We have supported with the training of oncologists, pharmacists in oncology, and oncology nurses. Recently, through a partnership with the Ghana Medical Association and the Ghana College of Physicians and Surgeons, we are going to establish a medical oncology program in Ghana. We've been the first company to introduce automated immunohistochemistry in Ghana by placing our innovative Ventana machines in 3 teaching hospitals. All this we've been doing while saving close to $19 million in partnership with the government of Ghana. It's noteworthy that 70% of the measurable social and economic benefits are derived from treating cancer when it is in the early stages. To fully harness this return on investment and transform the burden into economic growth, we must prioritize strategic long-term co-investments requiring strong political will and clear policy action from governments. This may include involving health technology assessments to include social and economic considerations, rewarding innovation that drives productivity and GDP growth. Let us leave this session committed to transforming this cancer burden into Ghana's next economic breakthrough. Let us measure success not just by treatments delivered, but by the years of life transformed, the families kept whole, and the future is made possible. Thank you.
Thank you very much, Roche. So invite quickly Pfizer to also come and give us a very brief remark on your journey in cancer care in Ghana so far. Pfizer, ladies and gentlemen.
Thank you. Dr. Chairman, standing on all existing protocols, I would like to begin by sharing Pfizer's commitment. I believe it is that irrespective of where someone finds himself, whether in a poor country or in a rich country, there should not be any limitation to access to healthcare. Through this commitment, Pfizer announced in 2022 that it's offering all of its medicines, both new and old, at not-for-profit to 45 countries in middle to low-income countries, for which Ghana is part of. As a result of this commitment, many patients in Ghana have benefited immensely through significant reduction in the cost of their cancer treatments. It goes without saying that for many of the new targeted therapies, patients have enjoyed as much as close to 60% reduction in the cost of treatment. For this reason, as you highlighted earlier on, patients do not need to sell their properties in order to get care. In addition to offering all medicines at not-for-profit, Pfizer is also offered to support health system strengthening efforts. As a follow-up to this, we are also supporting the training of 2 medical oncologists to be stationed in areas for which we don't have medical oncologists. I believe this intervention will markedly help reduce the long distance patients with cancer will have to travel to seek care. And sometimes the cost of travel alone is a big prohibition or inhibition to accessing care. And I believe if these oncologists come back, they will contribute to the effort of our sister company, Roche. I'll highlight briefly through the support of the Pfizer Foundation, which JPIGO is currently implementing or running. I believe over the course of this program, we will see significant impact in terms of quality of care for patients who have breast cancer across the country. I would like to use this opportunity to commend the leadership of the Ministry of Health for first leading Pfizer Accord since its announcement, because Ghana is one of the lead countries which implemented this program. I also use the opportunity to commend the Ministry of Health and all other stakeholders for putting together this first cancer forum. We remain committed to working hand in hand and supporting the Ministry of Health through the implementation of key aspects or key decisions from this forum, and also looking forward to continued engagement of NHI, the Mahama Cares Foundation, a trust fund, to see how we can further enhance care for patients who have cancers in Ghana. Thank you.
Thank you so much, Pfizer. Indeed, if there's any single condition that tests the resilience of our health systems right across the lifespan, that is cancer. And indeed, it takes a whole village to treat cancer. So please bear with me as we continue to call on the village members who treat cancer by inviting Dorothy's Hope Foundation, if they are here, also to give us a brief remark. That will be followed by Breast Cancer Society of Ghana, and then, of course, the mother of all the foundations, Mahama Cares Foundation. They will end our presentations. Dorothy, are they here?
Good morning, ladies and gentlemen, esteemed guests and fellow advocates. I'm honored to be here present with you this morning, and I'd like to first of all thank the Ministry for this great initiative. Dorothy's Hope Foundation was birthed 11 years ago out of turning my pain into passion and a need to save lives in breast cancer. I'm a survivor for more than 20 years of breast cancer. Breast cancer is a global health issue that affects millions of women and families worldwide. As an NGO dedicated to breast cancer, our mission aims to make tangible impact on society. Our work focuses on 4 key areas: data collection, support, research, and educating women. We educate women about the importance of early detection, provide support to those who are affected, and fund research for better treatment and cure. Through our efforts, we aim to increase awareness about breast cancer and its risks. We aim to promote early detection and screening, provide emotional and practical support to patients and families, advocate for better healthcare policies and resources. I'd like to emphasize the importance of government to NGO collaborations in combating breast cancer. In order to reduce the death rate, the Ghanaian government can support NGOs in several ways. I'll name a few. By providing funding for mammography and other cancer screening machines and equipment in public hospitals. By developing policies for early detection and treatment protocols. Increase access to affordable cancer treatment and medication. Support public awareness campaigns and educating programs. Facilitate partnerships between NGOs and healthcare institutions. The Ghanaian government can also support public awareness campaigns and educating programs by allocating funds for mass media campaigns such as TV, radio, and print, by partnering with influencers and others to amplify the message. It is also incredibly important to integrate breast cancer education in schools and the school's curricula. Organizing community outreach programs and workshops, creating engaging content such as infographics, videos, podcasts, to share all this online. These efforts can help to increase awareness, reduce the stigma associated, and encourage women to prioritize their health. Ladies and gentlemen, additionally, a compilation of a database of cancer NGOs in Ghana is crucial. NGOs can coordinate efforts, reducing duplication and ensuring patients receive comprehensive health care. Just imagine being able to cover a wider demographic when conducting screenings and outreach programs. This same database will enable NGOs to achieve the following: foster collaborations and partnerships, enhance resource sharing and allocations to improve data collection and research, increase the visibility, support for NGOs from policy decisions and advocacy efforts. This database of cancer will also improve the referral system. Healthcare providers can quickly find and refer patients to the relevant NGOs for support and resources. Ladies and gentlemen, donors and funders can also identify credible NGOs to support. Ultimately, this database can also lead to more effective support, better outcomes, and save lives. It will be a game changer in cancer care in Ghana. Thank you so much for having me.
To do this individually, but it's always tough to work together across different disciplines. And yet, the best way to defeat cancer is through a multidisciplinary approach. We invite Breast Cancer Society to give us a brief message. There's a lot of talk about breast, prostate, brain.
Thank you. I'll be brief. It's Breast Society of Ghana. It's Breast Society of Ghana. Dr. Chair, thank you for this opportunity. I'll stand on existing protocols. So the Breast Society is a collaborative society. We have healthcare professionals of all cadre, not only those who are in specialist cancer care, but all the way to primary level. We have advocates, individuals, and we have breast cancer survivors as well. And it is our vision to see a Ghana where high quality, comprehensive breast care is accessible to all, irrespective of your income, your geographical location, or the stage of your disease. And this we hope to achieve through our mission, which is to strengthen the capacity of healthcare professionals, advocates, and communities to deliver evidence-based clinical and social interventions that improve breast health outcomes across Ghana. So a few of the things we do a lot of education through our CPDs to improve the standards of care and practice. We do training of healthcare professionals. We are into awareness creation. We have 2 research projects ongoing, and we have some experience in navigation and patient support. And key we do also is advocacy, advocating for screening, for treatment, for patient support. And so on behalf of the Breast Society of Ghana, I would like to pledge our support to the ministry and all partners in the cancer space, that we will join hands to expand public education, enhance screening, training of healthcare professionals, and advocacy for equitable access to evidence-based treatment for improved patient outcomes. We also bring on board the technical expertise and knowledge when it comes to developing screening, treatment guidelines, supportive care, and you can count on us for that. Together, I believe that we can change the narrative. So as our motto goes, joint action for breast care. Thank you.
Thank you very much. So to round up, of course, we have the mother of all our foundations now, and we hope that will be the vehicle, as suggested by Dorothy's Foundation, for all CSOs and NGOs to be able to channel their support through. It's critical that we do that. And so we invite on stage Madame Obobia Dakopoku, who is the administrator for the Ghana Medical Trust Fund, the Mahama case.
Thank you very much. Good morning to all of you. Dr. Chair, all protocols observed. Thank you for the privilege to speak at this important gathering. I also wish to extend my sincere appreciation to the Ministry of Health and all partners for organizing such a laudable forum that seeks to touch the very heart of cancer care. Today's conversation is not just timely, it is necessary, and it reflects a shared commitment to building a more resilient and equitable healthcare system. The theme, Transforming Cancer Care in Ghana, a roadmap for sustainable prevention, early detection, equitable treatment, and resilient systems, is critical to what the outcomes of cancer care in Ghana will look like in the next few years. The Ghana Medical Trust Fund was birthed out of compassion and to stand with every Ghanaian living with chronic illness, especially when the journey becomes overwhelming. Our mandate is simple but profound, and our work is centered on 4 pillars, so that no Ghanaian, regardless of their economic standing or location, faces the burden of chronic illness alone. We look forward to reducing the financial burden on patients, strengthening healthcare facilities with essential technology, develop specialist capacity through training of our medical doctors, nurses, and health professionals, and advancing research and innovation. Cancer care sits firmly within this mandate. The realities of cancer in Ghana are real. Across this country, families are losing everything: savings, businesses, and property. They are doing this simply to keep their loved ones alive. The truth is, no matter how wealthy you are, 5 years of battling a chronic condition will shake even the strongest financial foundation. This is the reality we are here to confront. Late detection, high treatment costs, inadequate equipment, and limited specialist availability remind us that the cost of inaction is measured in human lives. So as a fund, we stand ready to play our part. Today, I wish to make two commitments. First, the Ghana Medical Trust Fund pledges its full support to strengthening cancer prevention, early detection, and equitable treatment across the country. Secondly, we welcome every discussion, partnership, every proposal, and every innovative idea that will help us build a sustainable financing pathway for cancer care, especially for the most vulnerable Ghanaian. No single institution can transform cancer care alone, but together with government and leadership, private sector partnership, development partners, and the expertise of our medical community, we can chart a future where cancer no longer steals potential livelihoods or hope. On behalf of the Ghana Medical Trust Fund, I look forward to the insights and solutions that will emerge from this forum. We stand ready to collaborate, to co-create, and to contribute to a Ghana where quality cancer care is not a privilege, but a guarantee. Thank you very much.
Undeniably, the challenges in the health sector is enormous, and the Ministry of Health can't shoulder them alone. It is a collaborative effort. Another round of applause for all our partners. Dr. Chair, before we proceed, permit me to use some few minutes to acknowledge some individuals who have joined us here today. Let me first acknowledge the presence of our online participants. Some people are joining us online, and it's very prudent that we acknowledge them. So if you can hear us, our online participants, we acknowledge your time for joining us online. We also have here Dr. Osei Kufo Afre, the Regional Health Director of the Bono region. We have here Dr. Josephat Nuzal, Regional Director of Health Services, Upper West Region. Dr. Kwabena Sapong, Regional Director of Health Services, Northeast Region. Dr. James Bia, Deputy Executive Director of CHAG. We have here Dr. John Eko Otu, the Regional Director of Health Services, Savannah Region. We have here our mother, Dr. Beatrice Adai Wiafi, the CEO, Breast Care International, Peace and Love Hospital. We also have here Dr. Bafo Iwa. He is a consultant and clinical radiation oncologist. He is our immediate past director of the Technical Coordination Directorate of the Ministry of Health. Doc, you are welcome. We also have here Dr. Paulina Clara Apia from the Western North Region. We have here Dr. Brahma Baba Abu Bakari, Regional Director of Health Services, Upper East Region. We have Dr. Achu Dodo, Regional Director of Health Services, Volta Region. We also have here Dr. Fred Adomako Boateng, Regional Director of Health Services of the Ashanti Region. We have here Dr. Marion Otu, Regional Health Director, Western Region. A round of applause for all of them. Thank you so much for joining us. Very soon we'll be having our keynote address, but before I introduce our keynote speaker, we've been bombarded with so much talk. We need to relax the mind, and so I have the honor to call here our cultural troupe for a display. If it gingers you, feel free to get up and dance. Distinguished ladies and gentlemen, it is now time to hear from our keynote speaker. He mounted the stage early on when the program started, and he'll mount it again. Today, he's killing two birds with one stone. Representing the sector minister, the Honorable Kwabena Akando, is the Chief Director of the Ministry of Health, Mr. Desmond Boateng.
Thank you very much, MC. I'm back onto the stage again, now representing the Sector Minister for Health in the person of Honorable Kwabena Akando. He's requested that I convey his sincere apologies to all of us who would have wished to be here himself. But there is an equally important assignment that he needs to attend to. That notwithstanding, I'll proceed to read the speech on his behalf. Dr. Chair, Advisor to the Minister for Health, the Administrator for Ghana Medical Trust Fund, Heads of Ministry of Agencies and Directors gathered here, our development partners, reps of CSOs and NGOs, experts and practitioners, academia and research institutions, distinguished ladies and gentlemen. Once again, good morning. It is both an honor and a solemn responsibility to address this distinguished forum today. We gather not merely as professionals and policymakers, but as a united national force confronting one of the most formidable health challenges of our time, and that is cancer. Dr. Chair, cancer is no longer a distant or abstract problem. It lives among us, in our homes, our communities, our workplaces, and affects our mothers, fathers, children, and neighbors. Globally, cancer claims more than 10 million lives each year. Here in Ghana, breast, cervical, prostate, and liver cancers continue to rise, too often detected at an advanced stages, where treatment becomes more complex, more expensive, and less successful. This is not simply a clinical issue. It is a social, economic, and moral imperative. The World Health Organization's Global Action Plan for the Prevention and Control of Non-Communicable Diseases calls for bold national leadership, integrated strategies, and inclusive partnerships. Today, Ghana stands ready to answer that call. Our commitment to cancer prevention and control is firmly established within our national policy frameworks, the National Health Policy 2020 and the Universal Health Coverage Roadmap 2020 to 2030. Both identify cancer as a major public health concern. More specifically, the National NCD Policy and Strategy 2022 elevates cancer as one of 6 priority NCDs deserving sustained investment and coordinated action. This underscores our national resolve to build a strong, evidence-based, people-centered system capable of detecting cancers early and providing comprehensive treatment and care. To alleviate the burden on households, the NHIS continues to provide comprehensive coverage for 4 childhood cancers: acute lymphoblastic leukemia, Burkitt's lymphoma, retinoblastoma, and Wilms tumor, as well as breast and cervical cancer. Consideration is ongoing for the inclusion of prostate cancer, given its growing significance among men. Ladies and gentlemen, I am pleased to announce a major breakthrough in our national cancer response. Ghana has officially subscribed to the WHO-led global platform for access to childhood cancer medicines. This historic step guarantees access to high-quality, affordable, and reliable childhood cancer medicines, helping us eliminate stockouts, combat substandard products, and give every Ghanaian child diagnosed with cancer a fair chance of survival. Distinguished guests, our overarching health agenda is anchored on transformative interventions designed to break down the long-standing barriers to equitable health care. One of the boldest of these interventions is the Ghana Medical Trust Fund. Now fully operational, the fund, popularly known as Mahama Cares, is a pioneering reform in sustainable and equitable health financing. Championed by His Excellency President John Dramani Mahama, it provides financial protection for patients experiencing catastrophic health expenditures, particularly those needing expensive treatments not covered under the NHIS. Dr. Chair, today I am proud to announce that beginning next year, all cancer treatments in Ghana will be covered under the Ghana Medical Trust Fund. This is a historic policy shift. It means that every Ghanaian diagnosed with cancer, regardless of income, location, or circumstance, will have access to timely, life-saving treatment without fear of financial ruin. From diagnostics and advanced imaging to chemotherapy, radiotherapy, surgery, and supportive care, every essential component of cancer treatment will be fully supported. This program will serve as the financial backbone for comprehensive cancer care, protecting families from catastrophic costs and ensuring true equity in access. Complementing this is our quality-focused free primary healthcare initiative, which remains central to Ghana's journey toward universal health coverage. For cancer control, its impact will be transformative. Free primary healthcare will, 1, expand public education and awareness, 2, scale up community-based screening, 3, facilitate early detection, 4, strengthening timely referrals, and 5, improve access to diagnostic and treatment services. By removing financial and geographical barriers, this initiative will significantly reduce cancer mortality, especially among vulnerable and underserved populations. Ladies and gentlemen, despite our achievements, our cancer response remains fragmented. We have passionate professionals, strong institutions, and committed partners, but we lack a unified, coordinated national framework. Today's forum represents a turning point. We are here to, 1, present the ministry's strategic direction for cancer prevention and control. 2, map the landscape of stakeholders and interventions. 3, identify sustainable strategies for governance, care delivery, and resource mobilization. And 4, begin the development of a 5-year national cancer strategy, 2026 to 2030. This new strategy will replace the expired 2012 to 2016 edition and establish a coherent roadmap for the years ahead. In the coming months, the WHO will support the ministry in conducting a comprehensive impact assessment, which, alongside the outcomes of this forum, will form the basis for the National Cancer Situational Analysis. But let me emphasize, we cannot do this alone. The Ministry of Health will lead, but its leadership must be collaborative, drawing on the strength of our service delivery agencies, the teaching hospitals, research institutions, development partners, CSOs and NGOs, the private innovators, and the key non-health MDs. Most importantly, it must elevate the voices of patients, survivors, caregivers, and families, whose courage and lived experiences guide us toward compassionate and effective solutions. Our goal is to build a national cancer control framework rooted in equity, access, quality, and accountability, aligning with the WHO's Integrated People-Centered Health Services approach and SDG 3. Ensure healthy lives and promote well-being for all at all ages. By the conclusion of this forum, we aim to, 1, define a clear national direction for cancer control, clarify stakeholders' roles and partnerships. 3, identify priority strategies for sustainable, comprehensive care. 4, strengthen governance and coordination mechanisms. And 5, achieve consensus on a revised national cancer strategy. This strategy will guide our investments, inform our policies, and measure our progress. And timely and ultimately, it will stand as a solemn promise to every Ghanaian diagnosed with cancer that they are not alone and that their nation stands firmly with them. Dr. Chair, as a son, a father, and a citizen, I have witnessed the pain that cancer brings. Yet I have also witnessed the extraordinary resilience of our people, the skill and dedication of our health workers, and the hope that even the smallest intervention can inspire. Let this forum be the moment to transform that hope into action, action into policy, and policy into a healthier, stronger, and more compassionate Ghana. Let us be bold, let us be united, and let us make history. Thank you, and may this forum mark the dawn of a new era in Ghana's fight against cancer. And I quote Mahatma Gandhi, "The future depends on what we do in the present. Thank you once again for your kind attention.
Please clap louder. That's my future employer. Oh, Chief. Sorry, thank you so very much. I think we have more acknowledgements, so we'll do that. And with your permission, organizers, I think Chief has another pressing engagement. So with your kind permission, because I want to be kind to him, I don't know, maybe you employ me. We'll have to take the photographs so that he's not missing for him. You don't need to Photoshop him, okay? And then after doing that, we'll probably continue with the break. And when we come back, we'll listen to the real world stories of the families and the people who've been talking about the whole morning. And then we'll kick off with the second part of the program. But before that, Mabel, am I ready enough to introduce them? We have, biological, Dr. Kofi Amokodie, Regional Director, Health Service, Otirejin. Then we have Mr. Ingmar Struss, lead NCD's Global Health Unit of the Bayer Pharmaceuticals. And then he has his colleague who's into the, I'm sure is Adolescent and Youth, Young Adult Integrated Healthcare Initiative. And then we have Marini Kone, Bayer Head of, Dr. Fonsano. Also from Bayer, Head of Something Operations. Horrible handwriting by the doctors. I would not want to forget the chief executives of all our teaching hospitals. We've kept hearing the names of the teaching hospitals here. I have spotted my chief executive, Dr. Park Sibedu. I need him to do something for me, so I'll mention his name. Chief. Okay. All right. So, and then I think for now, that's what we have. So with your permission, if we can't take the photograph, Dr. Siedu, so that Chief can leave, then we'll do the coffee break for people to walk around a little bit. Then we can start off with the real world stories. Please don't run away. Let me spot everybody's faces. So if second part starts, I don't see you, will write to you. Thank you very much. All right, so please, if you can lead us to where the photographs will be taken, please. Oh, there was a beautiful thing outside too. I thought we were going to do it there. Oh, the red carpet. We'll do it here. Oh, okay, all right. There's an opportunity to quickly go to the powder room and powder your nose and face if you want. 15 minutes for that. part. The Deputy Minister for Health is in. So if we can please grab our coffee, sit, and refresh ourselves while we work, please. If the protocol team can go out and bring all participants in, I'd really be grateful. So we start in 4 minutes. things have been very smooth because he's now cured, or let me say he's now treated. He's been treated. But prior to time, I've been through a lot. Even it's not easy to even receive a message from a hospital to tell you your son has been diagnosed of a cancer. All these things started way back before the 5 years ago. It was long ago. He normally feels some kind of pains in the abdomen and stuff. So it got to a time he really cultivated a habit of eating. I said, hey, boy, you've been eating a lot. You do eat a lot. I was complaining, my wife, why do you give him a lot of food? He said, well, that's it. Later on, we realized that he stopped eating, but he was complaining of stomach, and we're trying to give ourselves medication. We go to the hospital. The hospital said, well, come this time. Until it became severe when he had a swollen stomach. And then I said, oh, let's take you to the nearby hospital. So we went, and then we were asked to come again about 4 or 5 times. And then we were asked to go to a bigger hospital. Up and down, we did a lot of scans, and then they said, no, they need to do a biopsy. So out of the biopsy, I was given some few days to come for a medical report. So after the reports, my son was diagnosed of Burkitt lymphoma, as I said it earlier on. In fact, it hasn't been easy at all. That time, you have to pay for your own self. So I have to source from people, beg, borrow, and then been asking of unnecessary money from people. Others will turn me down. We'll be crying overnight. We didn't even know what to do. I remember when we were in the Ridge Hospital, one day, it even gave me a lot of pressure. In fact, I would say even the cancer is a minor thing, but the infection he got, it was so severe that I nearly lost my son. I remember this story, let me not say story. I remember this time when we were looking for a particular platelet. And then, United 7 don't do blood, but I had a very nice person in United 7 who said, no, I can help you out. So I was called to come for blood. In fact, it wasn't easy. When I was called to come for this blood, I go to this place, the President's house, the Flagstaff house, before I realized I forgot my car key. And then I was like, what's happening? I just heard a sound, my friend, are you crazy? I was hey. By this time, it was happening to me. I forgot to even drive to the Ridge Hospital. In fact, it was a whole lot on me. I really urge the government, when someone is diagnosed of this kind of disease, the pressure alone and the depression states parents will go through, even at the hospital, the thinking alone and the financial crisis. Thank God the government has done something about Burkitt lymphoma. They are doing a lot about it, I hope so. But at our time, nothing of that sort. In fact, the burden it will bring to parents is not easy. So after I got the blood, I came back. Immediately, myself, I got so ill. Very, very, very ill. I had depression and anxiety together. All this is because of the trauma I went through. I will urge the government again to help caregivers like me who are really serious and they want to give their son or daughter or their ward care, that the government should provide at least a place they can relax, some lunch for them, other place of convenience, and at least give them something little that will help them, because the kind of pressure I went through, it hasn't been easy. God being so good, my son is doing so well. He said, Daddy, the way I've been through this pressure, see children die, see this all kind of pressure, I want to become a medical doctor. I'll call on the government. He's really struggling, or he's really pushing hard to become a medical doctor, to push him to achieve his aim, to also help children with cancer. Thank you very much. So, my advice to the public, my brothers and sisters, parents at home, please and please, never do a home care medication. I will plead with you. It is not easy, because when my son started complaining, I never sat down. Yes, you have people to tell you, let's go here. In fact, if I should tell you my experiences with churches and other places, you have no idea. But what I want you to know is, cancer as we speak, it is real. It is not a spiritual thing we normally talk about. If there's anything you are seeing which is not clear, or you have complaints in the child's stomach, excessive pains, and then a headache and stuff like that, please get to the nearby hospital. Don't consult any other person, get to the nearby hospital. Thank you very much. So, I'm Gabriel Amponsa Gadri, a graduate of Labone Senior High. I was, some time ago, I would say 5 years ago, diagnosed of cancer. That's Burkitt's lymphoma. And then, I've been through a lot, I would say. And not only me, but my parents, and even the doctors as well. I'll mention Dr. Salifu, who has been the main doctor during the success journey. And then Dr. Blue and the rest. But then, it started like this. I don't know how I said, I don't know the cause or the root of the sickness. But the symptoms, I'll mention something like swelling stomach, and then there's a lot, tiredness, and then headaches, fever, and the rest. So I used to eat a lot, so my parents started complaining, why do I eat a lot, but I still stay the same. The only thing I have, the only thing that increased in my body was my stomach. I didn't take it seriously. And we just laughed at it when they said it. But later I stopped eating. And then my parents were then worried about what's going on. So when I went to school, my friends talked about it. Why is my stomach has come there? What I eat early in the morning. Then my grandmother also complained. Then the next day, we took it to the hospital. So that's where it started. The doctors started and asked me to go for this scan, this test, so I will find out. But then it was difficult. So later, when we were directed to Ridge Hospital, we went through biopsy, where they discovered I had cancer. So I was supposed to go for treatment. But unfortunately, I was going to write BEC, but the thing became severe to the extent I wasn't able to write. So I was supposed to go to the next writing race here, which really hurt me, I would say. Because I planned my life knowing that by this age, I'm done with school. And then, as a child, I had a big dream. But God being so good, I'm done with treatment, and I've been cured of cancer. Because of the trauma and the pain I went through, I've decided and I've planned that I want to be a physician. But I will not say I want to save life, because I'm not going to save life. But I want to be a vessel that God through me to save life. But I want to see parents, my children coming back, kicking. I want to see people smiling as I'm fine now. Because I know that every tunnel, there's a light at the end of every tunnel. And I believe
that if the government help us, if the parents help the children, we can work together, not to say prevent it, but to help reduce or cure the cancer. Or if we are able to detect it early, that's why we'll be able to cure it. So at one time, there wasn't anything like support from national insurance or something, but now I know the insurance has subdued something, so it has gone down. But I still urge the president to help us, or the government to help us, so that the parents will feel comfortable and we reach the children to can have some peace of mind as we're taking our treatment. I would then encourage each and every children who is also going through this problem that they shouldn't give up. God is with us and will always be with us. Thank you.
My name is Georgina Settle Kumanjaga. I'm a breast cancer survivor, a counselor, and the executive secretary of the Breast Society of Ghana. My breast cancer journey started in 2017. It started with just a lump, a painful lump for that matter. Ignorantly, I did not go to the hospital immediately. I resorted to home medication for 3 months before reporting to the hospital. Fortunately, it was still localized. It hadn't spread as of the time of diagnosis. And I had to go through some series of treatment, including a lumpectomy, then chemotherapy, then a mastectomy. Then I went on to do radiotherapy, and I'm now on hormonal therapy. This is a daily pill to take for 10 years. I've done a little over 6 years now. I must say the journey was not easy. Chemo had a very, very bad toll on me, but I knew it was something I needed to face if I wanted to survive. Going through this, you need support, financial support, emotional support, psychological support, and even spiritual support. And I was fortunate I was able to get some of this support through the journey, and that made it less stressful for me. But when I needed the most support was support to navigate the complex health system. And that was why I decided that if God granted me the grace and I survived, I would be a navigator, a patient navigator who would help hold the hands of others who will be diagnosed after me, so they are able to go through the system less stressfully. And so that's what I've been doing since 2019 when my active treatment ended. And given the opportunity at the Breast Society of Ghana to be their executive secretary, this also gives me a bigger platform to destigmatize breast cancer, to speak and also encourage or inspire other survivors to also become advocates like I am. And I must say that yes, though it wasn't an easy journey, one thing I have learned is early detection and then timely adherence to effective treatment is a sure way. I've not only survived for myself, I've survived for the many others that have been diagnosed after me, as I have now become a beacon of hope. You too can survive.
My name is Eric Klober. I'm a trained biochemist. I work with the food industries. At the moment, I am retired. But when I was working, it was mainly the flour mills. In 2004, I had a mild stroke. In treating me, my doctor advised me that I should also take care of my prostate, because it was something that was affecting men in Ghana very much at that time, and people didn't have any knowledge of it. So he told me I should be checking my prostate regularly, and this I did through PSA tests. My PSA results at that time were good, always below 4. Until 2017, when I was 68 years old, and then the prostate PSA levels jumped to 7. And my GP told me I would have to check it again because she could not understand why it had suddenly jumped. Now, this was as a result of my regular checkups. Every year I have physicals done. My liver, my kidney, everything, I checked it. And it was as a result of it that I realized my PSA had shot up. When this happened, I looked for a urologist, and I ended up at Police Hospital, where the urologist checked me and advised me that I should have a biopsy done of my prostate. He did all sorts of things before he told me to do this, because he did direct DIE, direct rectal examination, and other things. So he did the biopsy and took the samples to Standards Board, and it came out positive that my prostate was cancerous. Now, when that happened, he referred me to Kolebu, oncology department, the radiotherapy section, where I had all sorts of tests done, especially whether it had spread to other parts of my body. It was realized that, okay, it had not. And therefore, I could be put on immediate treatment. And this was what we call brachytherapy. Brachytherapy involved putting some radioactive pellets into the prostate. You will be under general anesthesia, so you wouldn't know what was happening. So I had it, and then after a month, I started with regular linear radio treatment again, radiotherapy treatment again. I did that for 30 sessions. When I ended that, I had to do more scans. In fact, one of the things is that you keep on doing scans throughout the treatment. And when I did the scan, and they realized that really the radioisotopes had been placed at the correct places, they told me to be coming for regular review. It was, I think, we started with every month or so, and then it progressed to every 6 months. Right now, I go for review annually. And when I go, they ask me, do you have any problems anywhere? They check me. But as you can see, I'm perfectly all right. I feel great. In fact, since that treatment, we have passed through COVID. I survived it. I have undertaken trips that took me over 20 hours of flying at a stretch. And considering my age, I think to undertake all that, I still feel good. By the grace of God, I can say that I'm in good health. And I really feel great.
Okay, very inspiring stories. One theme, though, is that geography, all located in Accra. The question is, if you are 300 kilometers, 600 kilometers away from the radiotherapy center in Accra, in Kumasi, what would be your story, right? So that's why we are here, to make it possible that the stories come from everywhere across Ghana. So we'll quickly start the second portion, but let me take the opportunity to introduce in our midst again the Global Strategy Director, Access to Healthcare for Amgen, Dr. Philip Anderson, who is in the house. So, Dr. Chair, Senior AB, with your permission, we'll carry on with the second portion. But we have a very important, I haven't missed her. Oh, come on, Ernest. I know my spectacle is old, but I can still see through it. Okay, even if it's dark, I'll still see her. Anyway, so it's my singular honor to introduce to you. Now, I didn't even want to mention her name first. Now, you've made everybody know that I said. A very special guest in our midst who describes herself first as a Ghanaian, then a surgeon, an academic. I'm not sure her boss will be happy with this because she put the politician last and says that she's currently the Deputy Minister for Health and MP for Esikado, Ketan constituency. She is a US-trained double-board certified general and reconstructive surgeon. She has taught surgery for over 15 years at the University of Utah and lectures at the University of Cape Coast. How did Cape Coast secure her? She is founder of the Healing Hands Foundation, a fellow of the American and Ghana Colleges of Surgeons, and a passionate advocate for women's and children's health. Ladies and gentlemen, our Deputy Minister for Health, Honorable Professor Dr. Grace Ayensu Dankwa.
Thank you so much, everyone, and is it good afternoon? Good morning, or is it good afternoon? Is it afternoon? Good morning. And sorry, I just came because I had an Africa CDC meeting at the Alisa Hotel. So thank you for having me. I'm very privileged to be here, and thank you for your kind introduction. I'm very, very excited to be here. In fact, when I woke up this morning or since last week, this meeting was one of the meetings that no matter where I was, I had to attend. So sorry that I wasn't here earlier this morning. Only because I understand what we're here to do. As a surgeon specialist, I have had opportunity and privilege to take care of cancer patients from initial diagnosis, the consultation, the diagnosis, the surgery, the chemo, the radiation, whether it's neoadjuvant or adjuvant radiation or chemo, all of that stuff. I've been personally involved. I've also had opportunity to also counsel caregivers of cancer patients. So I stand here not only as a Deputy Minister of Health or as a politician, as he said, but I also stand here as one of you, because I have been through everything that most of you have been through here. I am also currently doing second opinion consultations. So that means that when somebody gets cancer or is diagnosed with a cancer, they bring all their documents to me so that I can confirm and look at all their radiology, their labs and everything, and confirm for them that it is true that you have prostate cancer or you have breast cancer or you have cervical cancer. So I'm with you, I'm here, I understand, and as a politician and a Deputy Minister of Health, I want to reassure all of you in this room that I am available for you. I'm available to listen to the issues, to see how far we can go as a country, and especially for my government with Mahama Cares. What Mahama Cares is is very simple. I know the CEO was here, but basically we have national health insurance. At some point, the national health insurance runs out, and people can afford the extra chemo, the radiation. The gentleman on the video was talking about when he had his brachytherapy for prostate cancer, that the money is involved. So when they reach that stage, Mahama Cares kicks in. Not only does it provide some funds to alleviate some of the financial issues, Mahama Cares is also going around, and what we are trying to do is to plug in some of the holes. The gentleman earlier mentioned the lack of radiation therapy places. It's only in Accra and Kumasi. So what if I, in my constituency, in the village in Ahantabasa, in Western region, what if I need chemotherapy or radiation therapy? Where do I go? So those are the things we are looking at. We are looking at if somebody has cancer, what is the trajectory? What do you go through? What do you do? Who are the best surgeons even in town? Who does breast cancer surgery? Who's doing prostate cancer surgery? Where are the chemotherapy? Where are the radiation? What medicines are we even using? So those are some of the things that the government has tasked us to do. So Mahama Cares, I pray and I beg all of you, pleading that let's accept it and help us help the system, help us help the country. Because what you tell us, the practitioners on the ground, is what you tell us is what we will use to make sure that this program works, because it will be very beneficial to this country. After that, we also have a program of the free primary health care. So hopefully, we will pick up the cancers from that level before they end up in our consultation room as end stage, as late presentation, or any other name we want to call it. If we can pick it up from the community, if we can pick it up from the CHIPS compound, if we can pick it up from the health center or the district hospital, I think that we can mitigate a lot of the issues that are happening once these cancers are end stage. So without talking too much, I want to say thank you. I want to appreciate everybody in the room. I also want to extend a long hand to all of you. I'm in the ministry. Most of you may have my number. Feel free to call me. Feel free to reach out to me. Feel free to bounce anything off of me, because this issue is an issue that we really, really need to curb it and also put a stop to it. Hopefully, Ghana will be the beacon for the rest of Africa and for the rest of West Africa especially. I'm just coming from the Africa CDC, and everything they talked about was Ghana. Ghana is doing this, Ghana is doing that. So let's continue along that trajectory, and let's make sure that our people have very good care. And also lastly, last but not least, is to ensure us that when we have patients, how we treat our patients is very, very important. Let's have empathy, let's care about them, and let's make sure that we get good health for all of Ghanaians. Thank you so much. Another round of applause for the Deputy Minister for Health. Doc, we are so grateful to you for your experience and the expertise that you have shared with us. Ladies and gentlemen, next on the agenda is a very critical presentation that will focus on international best practices and regional lessons for cancer control. And I have the honor to call on our WHO representative, who will come here to share valuable insights to guide our collective efforts. Ladies and gentlemen, a resounding round of applause for our rep.
Good morning.
Dr. Chair, Deputy Minister, let me stand on all existing protocols. Distinguished ladies and gentlemen, good morning once again, and thank you so much for the opportunity to make this very brief presentation. I think all of us gathered here are experts in our own rights, and so everything else I have to say has been said already, but just to provide us with some reminders. So I'll start with the growing burden of cancer, particularly in Africa, and the urgency for action. So as you can all see, the cancer burden is actually rising globally. We all know that, but particularly in Africa, the burden is significant and rising, with nearly 2,000 lives lost to cancer daily, and projections estimating for Africa for the figures to double by 2040. And again, in our part of the world, we know that this crisis is exacerbated by factors such as population growth, aging, increased exposure to carcinogens, unhealthy lifestyles, and infectious agents like HPV and HIV. The major challenges include, of course, as we have mentioned already, the late-stage diagnosis, really low awareness and education, lack of screening and diagnostics, high treatment cost, but as we have heard now, there is light at the end of the tunnel with the introduction of Mahama Cares, and again, looking at the whole continuum starting from free primary healthcare right through the early detection models will be strengthened at primary healthcare level. And so our situation here in Africa, again, many countries still face high out-of-pocket costs for cancer care, which really is unaffordable for large segments of the population living in poverty, leading to abandonment of treatment and poor health outcomes. So just to remind us, let me emphasize again, I know everybody here is an expert and you know these things already. So what works globally? So we'll look at the 5 pillars: prevention and vaccination, early detection and diagnosis, timely quality treatment, palliative care and survivorship, governance, and financing. So we pick them one by one. When we talk about prevention and vaccination, of course, Ghana, we have moved or made significant progress with HPV vaccination, and we know that it is a high impact intervention. And I remember a few years ago when we put in the application for Gavi support, we realized that the high cost was going to be a challenge for us, but thankfully the government was able to provide the necessary support for us to roll out, and that has been done successfully in a couple of weeks and months ago. Again, reducing risk factors, obviously, such as tobacco use, harmful use of alcohol, unhealthy diets, and viral infections, as I've mentioned already, and health promotion are core to prevention efforts. And it is important that we promote policies to reduce exposure to risk factors, as we have mentioned, and also advocate for legislation
supporting cancer control efforts. Again, we are looking at integration with primary health care. We have mentioned the free primary health care initiative, looking at reproductive, maternal, neonatal, and child as well as adolescent health interventions, and also interventions in schools. And then again, looking at catch-ups and multi-age HPV strategies. These will really strengthen our prevention and vaccination efforts. So in terms of early detection models, we have the PHC-led screening, and we tried to cite a few countries that are doing well in the African region, Kenya and Rwanda. And we know that primary healthcare screening really focuses on early detection and prevention across common malignancies using standardized tests and guidelines administered in primary care settings. And clear referral pathways and triage is vital, again, for early diagnosis and timely initiation of treatments. And WHO recommendations actually emphasizes standardization, strong communication, and patient-centered processes to optimize diagnostics outcomes and minimize delays. I really loved the submission from one of our heroes who mentioned that she is now a patient navigator. And so patient navigation really accelerates diagnosis by actively guiding our patients through complex healthcare systems, addressing barriers to care, and expediting each step to ensure that our patients receive the quality treatment that they deserve. Again, for community health worker engagements, in most settings, they are the patient navigators. They support the patients, help them to overcome obstacles such as language barriers and poor health literacy. They coordinate appointments, they provide reminders, and ensure that there is increased adherence to recommended diagnostic procedures. When we talk about diagnosis and treatment strengthening, as I've mentioned, we have a lot of our professors here and our clinicians. So we are looking at tiered cancer care networks, standardized protocols, and multidisciplinary teams, very, very essential. And to go back to talk about the provision and availability of standardized protocols, it is important that we adhere to standards to ensure that the treatment and the diagnosis are based on evidence, and expect consensus is associated with improved survival and clinical outcomes for cancer patients. So it's important that as a country, we use these tools that are available for us to strengthen diagnosis and treatment. And also, tele-mentoring and echo platforms is also essential. And it is important that we use or explore the use of telecommunication technology to deliver mentoring, training, education, and support remotely, which helps build knowledge and skills among healthcare providers or other professionals in various settings. I'm sure most of us know about the ECHO platforms, and these are very, very useful and prominent telementoring platforms that create virtual communities of learners by connecting healthcare providers and subject matter experts
through video conferences. And so it's important that we explore the use of these opportunities. Improved pathology, immunohistochemistry, and then again, telepathology significantly, as we all know, advances cancer control by enhancing diagnostics accuracy, accessibility, and treatment personalization. Again, for palliative care and rehabilitation, very, very important component, ensuring access to essential medicines, and using community-based and integrated approaches in our primary healthcare setting, ensuring that rehabilitation is an integrated part of cancer care, core cancer care, and also exploring the use of home-based support models is very critical. Sorry. In terms of governance, NCCPs, and financing, I'll just mention and reiterate what has been said already. We are in the process of beginning to develop our new NCCPs, and next year, hopefully by March, we have a team from IAEA and IARC working together with 3-level WHO will come in country to support us to conduct a very comprehensive impact assessment. And we see this meeting really as a precursor to that engagement next year. And that will really help us to identify our gaps, evaluate our previous NCCP, identify the gaps, and then be able to really structure a new NCCP. And then talking about evidence-based prioritization, it is important, and as we all know, this involves multi-level policy guidance, targeted investments, improving interventions, ongoing implementation, science, the use of it, and explicit consideration of health equity to maximize public health impact and optimize resource allocation. Partnerships, we all know strategic partnerships, extremely important in our setting. And in this, we combine expertise, resources, and outreach by combining and enhancing prevention, early detection, treatment, and care equity across diverse communities. That's why we have a number of our partners in here supporting the process. So as I conclude, what are the regional lessons from Africa? Integration of services really works, and I'm so happy about the free primary health care. We pray that it is extremely successful. Workforce capacity, which really transforms outcomes. And then again, data quality determines success. Partnerships really amplifies impact. And also we are looking at exploring tailored context appropriate solutions in our context. So these are just successes across Africa and the things that are happening. There is a project in Eswatini, training and building capacity, strengthening patient navigation to really reduce or bring to the minimum the waiting list for our clients. And then Côte d'Ivoire is doing so well in terms of primary healthcare integration for women cancers, especially when you look at the early detection models at primary healthcare level. They are doing extremely well. Kenya really is exhibiting a strong diagnostics pathway. And then Madagascar is also working with partners like UNICEF to ensure that cervical cancer interventions are strengthened. So as I conclude, What are the priority areas for acceleration? So all that I have said, we need to really promote healthy lifestyles through public education on the NCD risk factors, and they are listed here. We need to consider establishing national systematic cancer screening programs and implement organized and opportunistic screening strategies to improve early diagnosis. And I say this because I work within the partner space, within the NCD space. Sometimes you hear that, oh, a partner is doing screening somewhere, another is working in another region, which is all good. But how are we able to harmonize the data? Because it looks like we are still working in silos. And I think that the Ministry of Health should take that up really to ensure that coordination is strengthened. And then we should even have a suppository at the ministry, a dashboard, where at a glance, we know who is working where and what. These are very, very critical if we want to really make progress with our cancer control. And then develop and follow evidence-based treatment protocols, I've mentioned that, and guidelines, establishing tumor boards, which I know most of our tertiary facilities have at cancer centers for management oversight, improve diagnostic capacities and treatment facilities, including upgrading comprehensive cancer centers. And I know that a couple of months ago, the Mahama Cares team actually started visiting some of our cancer sites to ensure that they identify the gaps and challenges that would be addressed. And then again, decentralize palliative care services to subnational levels to improve accessibility and provide psychosocial support and rehabilitation to improve quality of life for patients and families. Lastly, we should look at establishing and strengthening a population-based cancer registry, and I know CCAN is very interested in that, to document at least 50% of all cancer cases, providing data for targeted interventions and research, improve human resource capacity for cancer control at all levels through training, education, and establishing multidisciplinary teams, forge functional partnerships within and outside the health sector to support integrated cancer control programs, and then secure sustainable funding and implement coordination mechanisms to support the coordinated implementation, monitoring, and evaluation of cancer control efforts. Finally, this is our call to action. Scale up cost-effective interventions, strengthen PHC-led diagnosis, invest in workforce and technologies, institutionalize palliative care, enhance data-driven decision-making, and boost domestic financing. Thank you very much.
All right, thank you so much, Madam Joanna Anson from the WHO. I've forgotten, they whispered your particular portfolio, but don't worry, I'll get it again. I'll mention along the line. I'm not so smart. The coffee's running out. All right, she did that beautifully in record time. So Dr. Chair, Senior AB, thinks that we should get all of you involved. So we will have maybe 3 to 5 critical questions. Let's divide it into lymph node levels. Level 1, level 2, 3, 4, 5. Let's do the dissection, okay? So Dr. Chair himself, you have to catch his eye, and then he will allow you to speak. So we have about 7 minutes for that. So very burning questions and contributions. Let's start out with Dr. Chair.
Yeah.
Any questions? Or a colleague from WHO did it very well. I remember when I was in WHO, we used to say WHO knows everything but does nothing. UNICEF doesn't know anything but does everything. UNDP knows nothing and does nothing. Yes, okay.
Hello, thank you very much for a beautiful morning and afternoon. But I have a very important thing that we need to look at. Everybody talks beautifully about cancer control, but the missing thing is human resource. It's a very huge gap, which is it's ignored, really, and I think we really have to do a lot to improve the training and most importantly to retain the experienced staff. I think there's a big problem with the young people just leaving. It's not just Ghana, it's everywhere. But without that, all your investment is actually going to collapse. So I think it's something to really think about.
Very good point. How do we improve training and how do we reduce Japan? Any comments? We just want to have some of the key issues so that when we bring to panel discussion. Yes. Yes.
Thank you very much. I'm Dr. Mrs. Augustine Abedu-Pepe, consultant radiologist and the head of radiology at Konfanochi. As we speak, we're talking about making early diagnosis and all that, but currently we don't have equipment to work with, let alone train. So now when we train our radiologists, none of them are able to go even into the hinterlands. When you send them there, they come back because they say that there's only X-ray and ultrasound, and they'll go rusty. So what can we do? I know Mahama Care has been going around to reach to some major institutions in at least every region, if we can get one that is well-tooled to be able to take care of the early diagnosis that we're talking about. Thank you.
Thank you. So we heard about workforce, equipment, retooling. Maybe we'll take one more.
Thank you very much. Beiwa Asaibusu, a clinical and radiation oncologist, Konfanochi Hospital. One of the observations we have made is late presentation of our cancers. For many years now, we've not been able to reduce the number of late presentations. One of the things I find, when we were kids, what we heard on radio used to be the gospel truth. Now, any information you put out there on radio about cancer and cure, and for the people who hear this, they think it is so. So they try these, and until such a time that things are getting bad, they wouldn't come to the hospital. Now, I want to know whether we could kind of censor the information put out there in public domain so that patients don't get unnecessarily deceived and then wait until it is late before they present. I don't know what role the Food and Drug Board can play in this direction. Thank you.
So information on the radio and the TV, usually they say this has been approved by FDA. How do we control that? Yes. We'll take the last one from Prof.
Thank you very much. This is Lorna Renner. I think data drives a lot of the decisions we make. What are we doing with regards to collecting data, both adult and pediatric cancers nationally in the country? When it comes to getting the data, I know individual hospitals may have, but then the system for generating it all so that we have a national data confidently to say this is so many cancers that are seen, specifically this, and the outcomes as well. Thank you very much.
Thank you very much. So 4 things have come up: workforce, equipment, information, misinformation, and data. I'm sure there are more as we go along. We will now move to the next session I understand the Deputy Minister will have to leave. Minister, thank you very much for coming, and we're really grateful that you were able to share. Yes, you go after lunch. Don't mind GTech, you are our professor.
All right. Well, I couldn't have said that. That was 3 seconds and boom, there we go. Okay, so beautiful questions. That sort of introduces our next topic, and we hope that we can have enough insight from that topic to be able to continue the discussion. So after that topic, we'll end up with a panel discussion to be led by Dr. Balfour. Okay, so we'll invite on stage to deliver a talk on ensuring equitable access to quality cancer services. Okay, I would like to invite Mr. Isaac Obentando, Data Manager and MNE at NCDP and Ghana Health Service, to help us with this discussion on ensuring equitable access to quality cancer services. And then we'll have the panel discussion after that. So Ghana Health Service.
Good afternoon. Dr. Chair permits me to stand on the already established protocol to proceed with this presentation. I am Isaac Obentando. I'm doing this on behalf of Dr. Wallace Odiko Olenu, the Acting Program Manager for NCDs, Ghana Health Service. So my presentation here is the landscape of cancer prevention, screening and treatment in Ghana. And I must say that most of the slides Dr. Anson presented earlier actually encompasses all that I have. But with this, I'm going to contextualize it within our Ghana settings. So this is the overview or the contents of the presentation. Yes, the statistics are so clear. We are all familiar with the numbers. We are all familiar with the urgency with cancers, the incidence of cancers in Ghana. We are all aware about the late reporting of these cancer cases. And we also know the existing challenges with infrastructure, with the health system that faces Ghana. But that notwithstanding, there is always light at the end of the tunnel, as our survivor mentioned. So yes, of course, cancers are part of NCDs, and you definitely will have strong links with age and lifestyle, genetics as well. We have them requiring long-term management at facility level, even to the community level. There are late diagnoses and then delayed care. This is, should I say, it's a common knowledge we have all come to hear today, even though we knew it before coming here. Then limited access to specialized care. This I would like to emphasize, that if you live in Upper East region, if you live in Bogatanga or Bunkuru-Guyoyo, you need to travel several kilometers to get to Tamale. If you're a child and your diagnosis is retinoblastoma, you can be diagnosed there. But if it is leukemia, you have to extend your journey to Kumasi or to Komfanoche for your diagnosis to be done. So you notice that people travel far and wide to access cancer services. And when you live in a rural community, the issues there are so glaring. And then financial burden. we all know a treatment for cancer is not cheap. It puts strains on the financial, strains on the household, even the government at large. Some of the common cancers in Ghana among women are predominantly breast and cervical cancers. Men face a lot of prostate and liver cancers. And I mentioned for children is leukemia, lymphoma, and Bowles tumor. For these cases, like we mentioned earlier, about 70% are diagnosed at a later stage. And then there are regional disparities with the incidence of these conditions. So this is just a slide showing the specific cancers that are leading mortalities in Ghana. Largely is the liver cancer followed by the breast cancer. So this is just an additional information to what has been said earlier. In Ghana, some of the risk factors have already been mentioned, but I want to highlight some with data backed by our STEP survey that was conducted in 2023. Alcohol consumption, the prevalence there is 28% within the rural setting. So in the villages, in the rural areas where there is no infrastructure, they are consuming more alcohol, and then that will predispose them to some of these conditions. In the urban setting is 18.6. Tobacco consumption or tobacco use is 4.8 nationally. And then a drill down of this data, we realize that females are more doing shisha. There are more females in shisha than men. Obesity is also high among women compared to men, 49.8%. Physical inactivity in Ghana within the adult population, only 9.9% are meeting the moderate intensity exercise standards, recommended by WHO. So the risk factors are within us, they live with us. Oral sex has been implicated for pharyngeal cancers. And then, of course, environmental exposures, low awareness and misconceptions. A gentleman mentioned that the information the media, some media and social houses puts across, we give other religious and other agencies the freedom to deceive our clients. So at a later stage, when they are struggling, then they end up in our facilities. And then there's a weak integration of cancer care in the primary health care system. We've talked about the whole continuum of the cancer care, and critically is the prevention and risk reduction. Once we are able to do this well, of course, the others will follow suit. But we're hoping that the treatment, survivorship and rehabilitation, diagnosis and palliative care should be decentralized across all 16 regions, and if resources permit, even in all 261 regions in Ghana. So the prevention landscape that we do is more of health promotion, HPV vaccination that has just been rolled out, and across the 16 regions, Greater Accra was the lowest to, accept the vaccine. Tobacco and alcohol control activities also ongoing. We work very closely with FDA and other agencies to ensure the smuggling of these harmful substances are reduced to the barest minimum. Sanctions are being applied. We want to also streamline or bring together all fragmented and underfunded programs, behavior change interventions, and then social determinants such as poverty education. Ghana, we are blessed to have several policies that guide our implementation. We have the NCD policy which unfortunately will be expiring next year. So I'm sure the Ministry of Health have started taking steps on that. We also have the strategic plan as well. We have the National Cancer Control Strategy. It's in a draft stage as we speak. Tobacco control regulations is there. We have the FCTC document that was developed a few years ago with FDA, supported by WHO. So yes, we have all the policies, we have all the guidelines to ensure that cancer, early detection of cancer, management and control are guided by policy and work within the framework of the MOH direction. We also have supportive policies. I remember we worked with World Child Cancer. Children who are diagnosed with cancer normally go or suffer malnutrition. So we recognize that food and nutrition policies are available to enhance their management. And then the environmental health and occupation safety regulations. All these are available for Ghana to improve cancer care. Right. So yes, these are some of the documents that I have highlighted. And most of all these documents are donor supported. Yeah. So yes, as we speak, there are some screening programs for some cancers, specifically breast and cervical cancer. We are supported with other partners, JAPIGO, to do some breast cancer screening in selected districts. I must say that most of these activities are not nationwide. They are in project intervention district. So entirely, not everybody is receiving or receives some of these interventions. When you go to on screening coverages, I have mentioned this. Yes, we have in the STEP survey, we also found out that cervical cancer, for all the women interviewed, or in Ghana, just a little, was it 3% or 3% had ever screened for cervical cancer, which is so low. Yes, so these are some of the screening gaps. We are able to establish or intensify advocacy and awareness. So during Cancer Days, we join the global community to celebrate and create more awareness. We have that of childhood cancer, prostate cancer, and then breast cancer as well. For diagnosis, as earlier presenters have said, it is centralized in the southern parts of Ghana, a little being done in Tamale, but it is so unfair. There's no equitable here, no equity here. So you see, Tamale will be interested to pick a certain cancer, but because there's no pathologist, sample has to be taken to either Kumasi or Accra for diagnosis. So it kind of delay diagnosis. And these are the major challenges we currently face as a country. It's not different from treatment. People have to travel far distances to access treatment for cancer. And then we are happy to hear that Mahama Care is coming in to improve infrastructure, to make treatment so accessible to victims. And it's also going to complement NHIS to improve access. Yes, this Dr. Anson also mentioned this. It's very important that once you have survived or gone through the continuum, we ensure that you stay alive, just as the one survivor with prostate cancer is still living on and then constantly going for follow-up. So we expect that survivorship continues even at the community level. We have our nurses checking up on you and so on and so forth. Palliative, of course, is another continuum that requires that people are constantly engaged, but unfortunately, these services are predominantly at the tertiary facility, so we need to expand the coverage as well. So the key gaps have been mentioned. There's late presentation, Screenings are fragmented. There's no composite data systems. There's high cost. There's weak health system integration and referral pathway, and then our cancer registries. I think the medical trust funds would add this as a priority to their activities, since they are looking at all cancers in Ghana. And once we have a registry in Ghana, we'll have a tailored intervention, resource allocation, and do a proper planning for cancer. So yes, we have strategies not to leave people behind. We want to bring everybody on board, from rural to low incomes, women with low education levels. We want to ensure that cancer interventions, cancer services are accessible irrespective of your financial or educational background. So for equity, we expect that one has access to all the continuum of care to ensure that when you are picked up, you are diagnosed, you are put on treatment, and then you are being supported till you are well taken care of. Yeah. So the way forward, as a program, we want to strengthen prevention. We want to expand screening and then early detection. We also want to improve the diagnosis and treatment of cancer. In summary, we will say that as a program, we want the government to take certain responsibilities, increase investments in cancer services, especially diagnosis and treatment. We want GHS and MOH to integrate cancer interventions across all primary health care, especially from the CHIPS level. It is very important, because if the risk factors are well defined there, they are well disseminated there, people will readily walk to facilities to confirm whatever they are suspecting. Partnerships, a very key pillar within the health system. We need the partners to come on board. The service, the program cannot do it alone. We need you all to come in. And communities, yes, that is where the cases are. We need them to know what cancers are. We need them to know the signs and symptoms. We need them to take the ownership in reporting to the right places whenever they suspect any of these symptoms. Then clinicians, we have said a lot about them. We have the experts, but they are inadequate. We need to train more. So government owes that to the nation. Train more clinicians, put in more logistics so that cancer interventions can be widely spelled out. In conclusion, Ghana has made significant progress, but major gaps still remain, which is early detection. We're hoping that there will be equitable access to investment systems and coordinations and community engagement. Together, we can reduce late presentation and improve survival outcomes for all Ghanaians. Thank you very much.
Thank you very much, sir. Before we proceed, I would want to introduce Dr. Bright Edward Ejekumhe is the Director in charge of Procurement and Supply Chain at the Ministry of Health. Doc, if you are here, just give us a wave. Thank you so much for coming. And all directors here from the Ministry of Health, if we have not mentioned your name, we want to say that you are warmly welcome. We'll now delve into our panel discussion. Still bordering on the theme, ensuring equitable access to quality cancer services. We'll have our panelists from the Ghana Health Services, the Komfo Anokye Teaching Hospital, Cape Coast Teaching Hospital, Cancer Connect Ghana, World Child Cancer, Ghana Palliative Care Association, JAPIGO, School of Nursing and Midwifery, being represented by Dr. Mary Idrisu. So as you can see, the stage is being set for the next session. And this session, ladies and gentlemen, will be moderated by Dr. Bafo Ewa. A resounding round of applause for him as he approaches the dais.
We continue to acknowledge our online participants, and you are part of the panel discussion. So please put your thoughts and your questions in the message box. We'll try and read from there, and I'll speak with the media guys to see if we can pick one or two contributions online as well. So the macho men have brought the seats. Offer, it's up to you.
Good afternoon. I think this morning the chair said something that when cancer was not sexy, do that time, we wouldn't get this audience here. So I sat behind the podium, and then I was so excited that now we are all talking about cancers. Because 25 years ago, this conversation was impossible. And we've all been talking about decentralized access, affordability, universal health coverage. I think we're going to set the stage this morning. And to help me do this, I want to invite Mr. Isaac Cobain to join us at the podium. He is the data manager and MNE at the National NCD Control Program. Yep. And Dr. Thomas Opoti Kone, consultant gynae oncologist, Komfo-Anokye Teaching Hospital. And he's the first gynae oncologist trained by the college in Ghana. We have a rep from Cancer Connect Ghana, Mrs. Gloria Jansen. And World Child Cancer Rep, Mrs. Adwa Pinamai, join us. Ghana Palliative Care Association, Mrs. Winifred Otu. And Dr. Pa Kwabena Forsen from Jepago. And School of Nursing, Miss Dr. Mary Idrisu. Good. So panel members, you are all welcome. I first want to start with the teaching hospital. And at this panel discussion, I want us to be talking about solutions, not challenges. And we must be intentional because the Ministry of Health people are picking from whatever we are going to discuss. And there was something that we always read that nobody can decide to make a brand new start. But we can all decide now and make a brand new ending. So whatever we've been doing during the communicable disease era, now we are in non-communicable disease era. So in terms of our structure, our systems and our strategy, they all have to change. So my question is, some time ago, if you take our universities, University of Ghana, they were all in Accra. And it took GIMPA to move university education out of Accra to satellite units, and other universities followed. How can we the teaching hospitals adopt that model so that you are Kolebu, Konfanochi, who, Cape Coast, people from my village can feel your presence, since transportation, accommodation are some of the hidden indirect costs that we don't talk about. So when we are talking about access and affordability, if we are able to improve access and move closer to our clients, the district and some regional hospitals, we will reduce some of the cost burden. So what new things should the teaching hospitals intentionally do to improve access?
Yeah, thank you very much. Send my regards to you all. Yes, in fact, we can't talk about solutions when we've not identified challenges or problems. For the teaching hospitals, the challenges were there when it comes to cancer care. I'll give Konfanoche as an example and we'll move on. We identified a challenge, and I'll be speaking as a surgeon, gynae oncologist, but I think it encompasses all. We did not have any gynae oncologists. The country had people who were really into surgeries in the gynae oncology space, but we needed to formalize this. Together with the Ghana College, we had to come up with a program to get that manpower set up. From 2016 up to now, we've graduated 2 fellows with the Ghana College, and we have about 15 fellows in training, various stages of training. So in terms of capacity, we identified a challenge, and this is what we are putting in across all the teaching hospitals. And most of these fellows are in Kumasi, Kolebu Teaching Hospital, Ho, and then we have some few also coming in University of Cape Coast. I'm wearing 2 hats. Ghana College, because I'm the secretary to the Faculty of Obstetrics and Gynae, we developed a model that if the patient cannot access us, let's move closer to them. If the residents are not able to come, all of them come to the teaching hospitals for training, let's reach out to them. Let's get the consultants to visit them on a regular basis. And this is what we've done with Techiman as a satellite for Konfanoche Teaching Hospital in Obstetrics and Gynae Fellowship Training. The same thing applies to if we want to get to the patients who have less access. The major thing is to identify, which we've already done. In all these areas, in all these big hospitals, we know those who are very much interested in gynae oncology and speaking on that level. For which reason, they don't necessarily have to come to Konfanoche, but we've already made arrangements with them. They get cases, we review these cases online, and then they prepare these patients. We move to these hospitals so that the patient would not necessarily have to come. But yes, indeed, this comes with its own logistics. The challenges of transportation, accommodation, and all that. But that is secondary. But the major thing is we've identified this problem, and this is the measure that we are trying to put in place to get this thing running. Thank you. Yes, it is. We need the support to do it.
Talking about cancer, it's not only cancers are more than 100 diseases. So we are talking in general about cancer. So if you are addressing it, please let's address cancers in general. Let me go to Ghana Health Service. The teaching hospitals are doing their bit. You know, when you are in the teaching hospital, you get almost all the referrals from the Ghana Health Service. And I have been taught that if you are referring a patient to somebody, it's like giving the person money.
what strategies do you think Ghana has a need to be put in place to attract visiting specialist consultants to strategic hospitals to reduce travel time of patients?
Thank you very much, Prof. And good afternoon once again. With the service, what we plan to do and to discuss with the ministry is actually to map out all the specialists within our zones. And then once we're able to do this mapping of the specialists, we are able to zone them either the northern belt, southern belt, and then the middle belt, so that facilities during their trainings, during their capacity buildings, if they need to make any referrals, they refer within the zone if there is capacity. They can only go beyond the zone if there is no capacity. So this is one of the major strategy we want to adapt. And also to advocate with MOH to ensure the equitable distribution of these specialists within the country. And we will know the challenges with resources. People are ready to serve, but once there are no resources to use within the facility, they tend to waste. So it will all come back to ministry to ensure the adequate of infrastructure and equipment, so that when these specialists are equitably distributed and they are zoned, traveling all the way to Accra would not happen again. At least it will be reduced to the very minimum. So I think this is what I would say for now. Thank you.
Thank you very much. Now, Cancer Connect. We've been talking about access, affordability, quality cancer care. Can you please maybe define the quality care, cancer care that you all aspire to achieve, and how your organization can maybe collaborate with the ministry and then for us to achieve this? What will you see, like, in your own mind? How do you see quality cancer care? Okay, and how would your organization collaborate, support the Ministry of Health, to achieve that dream?
So for us, quality cancer care begins with the patient. We need to know what the patient needs, and then we work around that to get that quality for the patient. Because we may be sitting here talking about quality, but for the patient, it might not be quality for them. So we need to understand the needs of the patient and then work towards that. And for us, treatment is one. Quality treatment, what is out there, they need to have access to that. Access, apart from it being financial, they need to also be able to get to the place to be able to access the care. Another thing as well is most of our patients, we don't find them initially in the hospitals. We find them in the communities. They are in their home. How do they access services in the community? So that we've been talking about patients presenting late. How do they find access to those services in the community before they come to the tertiary institutions? Some of the patients really are health seeking, but they don't know where to go, who to ask, what to do. So by the time they get to the hospitals, they are termed late, but they started early. They may have found some traditional or herbalist around who listened to them or were available when they needed them, and therefore they went to them first. So most of them, it's not their fault.
And also the information we put out there. I think one of us mentioned about radio information, creating awareness, sending the right messages to people out in the community. Where do they go when they find something that is unusual? Yeah, so I would say for us, access starts from patients. What we do for them is important because it's about them. We're here because of them. And if we don't make them central to every decision that we make, I would say we'll be talking about quality, but we may have lost it.
So my follow-up question is, now you talk about the challenges. We want solutions. So from Cancer Connect point of view, we've heard from the teaching hospital, Ghana Health Service, how can we also collaborate to fill the gap? That's the follow-up question.
So what we've been predominantly, or we've been doing predominantly has been, again, in the communities, coordinating, navigating the care of patients. Because again, patient is told you have cancer or patient is told you have something. They don't know where to go. How do we coordinate that care? How do we help them first to even get diagnosed and then move on to treatment? And also, when it comes to, in terms of our navigation for the patients, it's not just in the communities, that while we move them also into the hospitals and continue with them as well. We educate them so that they understand their treatments, they understand the journey. We basically want to start with them at the beginning, and then we end with them when they have finished their treatments and then move them into survivorship care.
Okay.
So we're here to also say to the ministry that we're here not just for us as an organization, but if there are other NGOs available as well. We don't want to work in silos. We want to work together with them so that we can go far. So we may be situated at a particular location, but there are other NGOs that we can work with in other regions as well that we can push, the navigation far.
So let me follow up with World Child Cancer. We have several NGOs in the cancer space, and it looks like either we are duplicating or working on the blind side of the ministry. What do you think NGOs, CSOs should be doing differently going forward in terms of their patient support, advocacy, and follow-up from World Cancer Connect? I know you are doing a lot in terms of pediatric cancers, but right now we are talking more general about cancers. So I don't want us to limit ourselves to only pediatric. Whatever you are doing for childhood cancers can be, replicated by other NGOs. How do you all come together to make sure our cancer care is more comprehensive?
Thank you so much. Hello. Okay, all right. Thanks for the opportunity once again. So with regards to working together, as we have all heard, it takes a village to raise a child. So collaborative effort is really necessary. So what we can do is that within the NGO space, it would be good to have a mapping. We'll do stakeholder mapping to identify all the stakeholders and what they are doing at where, so that when we know what each and every person is doing at a particular point in time, then we can collaborate and work together, not to duplicate efforts. Now, the discussions mostly have centered on prevention and screening. With childhood cancers, let me delve into childhood cancers because that is what I want to talk about. It's not preventable, it's not screenable.
So whilst we are talking about PSA testing, breast examination, it's not applicable in childhood cancers. What we preach is early warning signs and symptoms, and that is something World Child Cancer is doing very well in collaboration with Ghana Health Service. So we create that platform, we have awareness creation, or we educate healthcare professionals, especially those at the primary healthcare level, so that they can be able to detect the signs early and refer appropriately. Let me add that with regards to the referral pathway for childhood cancers, we have a robust one in that the child can be tried if the child or a suspected case is found at a CHIPS compound. The person doesn't need to go through all the systems to a district, to a regional, no. You can just jump from a CHIPS compound straight to a treatment center. And that is something the stakeholders in the childhood cancer space have worked very well at it. So with regards to the awareness creation or with education, for instance, we continue to train healthcare professionals in various regions. After each training, we create a community of practice, a WhatsApp page, so that when anybody suspects a case to be childhood cancer, the person can put it on the WhatsApp platform and directives are given. I must say that we have had very impactful stories after each training. We had a training in Ahafo region, and afterwards, one community health nurse, she was able to refer 3 children, of which 2 of them proved to be cancers. So we're not looking at prevention per se, but we are looking at the need to create awareness through education, training healthcare professionals on the early warning signs and symptoms of childhood cancers so that they can refer appropriately. By solution, this is something, it's more of a project that we do. But looking long term, can the ministry embed these trainings into the NCD treatment and frameworks or the national treatment training guideline, so that whilst World Child Cancer is doing something, it is a plan, it is a priority for the government, so that training for healthcare professionals will continue, not to stop at a particular point. Yeah.
Thank you very much. Palliative care. We always hear palliative care, and it looks like palliative care is becoming an empire that when they get to the tail end, refer the patient to us. But we all know it should be integrated across the care continuum. If there's somebody going for screening, there should be a form of counseling before we start this. How can we integrate palliative care across the care continuum so that it will not sit at a place that as if it's a hospital that we need to refer patients for palliative care?
Thank you very much. Good afternoon, everyone. Like you described, palliative care has always been assumed to be at the tail end. And if we look at the presentations we've had this afternoon, it is always some sort of the last one to be mentioned. And we're changing the narrative. Palliative care has never been the last to resort to. Palliative care starts from diagnosis, because if we are making a clear palliative, say, incorporated diagnosis or breaking of bad news to a person, then you realize that they muster the courage to be able to take the information you are given. They don't run away for a while and then come back later when it is getting complicated. If we were integrating palliative care well, just as we've been able to mention it in at least 10 national policies, we wouldn't be having a difficult time bringing on board our patients and their families and making sure that we are treating them with complications. What we can do as an association, what we can do as palliative care practitioners is to ensure that, one, we are available wherever we can. But we also want to encourage that palliative care is not just meant for the specialists. This is where the conversation of creating the non-specialist competency frameworks comes in. Can we have a landscape where
if, say, I'm a community health worker or a community health nurse, I know exactly which part and aspects of palliative care I can implement at my point, and at what time do I refer to the next stage. This is the only way to be able to break it down into the communities. And if we are able to do that and implement it well as a ministry, say by 2030, we can really embark on a mission that palliative care should be accessed everywhere in the country. As we speak, accessibility is just about 8%, and that's woefully sad. That we've traveled this cancer journey for a while, and yet it doesn't go along with integrated palliative care until it is an afterthought or until we cannot do anything else. Another model which Ghana Palliative Care...
Tell us what we are going to do differently.
Okay.
This is what this forum want to pick from us. We must be into not what has gone on in the past.
Yes.
Going forward, if you live here and you have the resource, what are you going to do differently?
Okay, so another model we can quickly implement as a country is to ensure that home-based care are well regulated and we resource them to be able to utilize it. Palliative care especially does not need a lot of equipment or any much equipment basically to be able to implement. Wherever the setting, it can be implemented. So can we equip everybody that is within the community to do some implementations? Can we look at probably things like technology, AI, apps, or maybe community-based clinics? Can we look at care on wheels and stuff like that, so that it's moving from one place to the other? It will free our beds and it will make it easier for our patients to receive what they need, the psychological care, the emotional care, the spiritual care, right where they are, and wouldn't have to travel miles to Accra or Kumasi to be able to access what will give them quality and dignified life.
So palliative care can be implemented everywhere. And it can be integrated in all the
districts,
from screening, early detection,
yes.
And we don't need AI, it's just the human beings that have to change. Jipago, now I'm coming to the DPs. I have worked at the ministry, so I know how this is. You'll be at the ministry, there are so many partners in the space, but only few are known by the ministry. But you go out to the communities, you see development partners working with agencies. And when you zoom in, you look at, they are almost doing the same thing. And at times when you go out and meet people outside, look like they are spending so much on Ghana. But if you come to the ministry's account, there's nothing showing. What are the DPs going to do differently so that they register themselves with the ministry? I quite remember I used to work with a minister and we said, look, but I always answer audit queries. But when the resources are going, we don't hear about it. And this morning, as part of the presentation, we're also talking about governance. Because governance starts the ministry. So that if the resources, you don't give it to the ministry directly, but at least they must know. So that when it comes to accountability, you save yourself from going to the lower level. You go to the ministry that, oh, you asked her to go here, we've invested this amount, we want to know the output. What are development partners going to do differently so that we work as real partners? Not that I have my funds and this is where I want to put it To hell with you.
Thank you very much. I think this is an important question, and I would approach it two ways. One, I think that for development partners, implementing partners, really often our work is with funding from a donor, and the donor would have their interest. The donor would have targeted areas where they would want their money to be used within the country context that may be in question. At the same time, too, we know that the ministry and the government also have priorities. I think that the disconnect is, one, in knowing the pathway to access government and to access government priorities. Sometimes that is a missing point, and often traversing that process can also be a bit difficult. What you find is that the developing partners, the implementing partners, of course, for most projects, there's a scope to the project. There's time within which that project must be delivered. And that is where they may probably find ways to try and get this done. I acknowledge that the point you made is important about how the minister would be at meetings and be asked about this project in this region or in this town, and they may not have any idea about. But I think that one of the good things that will fix this problem is such dialogues. And of course, JPIGO, we're also supporting in that light. Convenings like this brings people of interest, and we have an opportunity to also engage with government at the top. I think that through these convenings, it will be important to have actionable points, including how to introduce projects. Which sector do we engage with first? Are there important MOUs that must be signed? These steps, if they are known and partners and development partners are aware, we would follow that path. But I think until now, largely, a number of implementing partners have not really seen this clearly. But I think that such convenings and dialogues, and for us, we're beyond this, looking at even quarterly dialogues, will open that landscape. And then you will find that developing partners and implementing partners would do the right thing.
Okay, so when these are done, Ghana has been teaching hospitals, they are advocating for partners to support them, and so this is one area that if partners come together and then we pull our resources together, I think we will achieve that. Now let's go to the academia, because one thing that to me has been sustainable all over the world is research. Research. Many of the things that we do, because they are not anchored on research, as soon as they are done, there are no footprints. And as a doctor, I always ask myself, the clinical method we learn in fourth-year medical school, if you practice clinical method very well, this early detection, we can solve more than 50%. In your consulting room, maybe if you are shy, asking the woman that, have you gone for your breast check this year? Have you gone for pap smear? Have you gone for this? At times, a pregnant woman will come with locally advanced breast cancer, and you ask yourself, during your antenatal, has anybody looked at your breast? And they are all in and you teach our workforce, what are you going to do differently in terms of the training of the future workforce, how to make sure whatever we learn in the classroom, when we come out, we practice them, and there's constant research to find out whether people are using the knowledge that they acquire from school.
Thank you very much.
Thank you very much, Doug. So for academia, I think I have two things to talk about. So I have done research. You go to the healthcare facility and somebody who has sat in the classroom will tell you that I don't have much knowledge in this area. During our training, it was given to us as presentations. I didn't actually absorb much. So such a person goes to the field and the person needs a top-up to build the capacity. But we are here, we've heard partners talk about the fact that some people are in Kumasi, some people are in Accra, but then we haven't heard anybody somewhere in Donkokrom, in Wase Kropon, and Abuna Salmai. We haven't heard them. So then we need to do the teaching well. If there is a need for you to call on external people who have the capability to teach, then we need to do that to be able to build the capacity. Again, we come to what have worked. When I came, I have listened to a lot of problems, now the solution. Where in the US, somewhere in 1990, there was this physician called Freeman, Harold Freeman. What did he do? When Harold Freeman realized that cancer care was not the best, and there were lots of, especially women, dying from breast cancer, he came up with a concept called navigation. And today I've heard navigation all over. Roche navigation, Depago navigation, Cancer Connect navigation. But then when we are bringing interventions, we talk about evidence-based, culturally sensitive, context-specific interventions. What did he do? Before the navigation program was rolled over, the 5-year survival rate then, it was 39%. When he brought navigation program on board, it rose to 70%. Stage 1 diagnosis of cancer was only 6%. After navigation program, it rose to 41%. Then late stage diagnosis, that was 49%, shot drastically. What are we doing? Now we are instituting navigation, but navigation program that we have currently is just looking at just a micro area. Navigation stems from screening to survivorship in the databases. We at University of Ghana, we have developed a navigation program. And based on our cancer-specific issues, our navigation program starts from screening to end of life. Because the person who has been told that nothing can be done should not be allowed to just go like that. That person must have a dignified death, quality of life. So we are calling on partners here, those who are doing navigation, that in the US, when that program succeeded, the government then passed an act to make it mandatory for all cancer centers to use navigation to drive cancer care. So I am also calling on stakeholders and the policy decision makers that we have developed navigation programs specifically for cancer care in Ghana. And for that matter, we need to pass an act. We need to look for people who can deliver navigation care. It is not about calling on specialties. We need community health nurses. I am a community health. I was a community health nurse some time ago. I didn't get a training to be able to diagnose cancer, no. Even my anatomy and physiology then was way down until I rose through. So I am thinking that let us get people to train them and let us institute these policies and let us make navigation mandatory in our healthcare system. Thank you.
So Ministry of Health will take this. Maybe when we are developing our cancer care strategy, it will come in before the act. So now I think, audience, I want to, yes. Okay.
So, Dr. Chair, with your permission, there are few comments online. We don't want to sideline them. So maybe we'll go ahead and read them and then we'll take a few from.
So from Inchiboisiako, he says, MOH should develop a regulation for the traditional healers and other healthcare providers on treatments of cancer as they claim. This one is also from Wato Esther Harriet. She says, Japaigo, in collaboration with Pfizer, is doing so well in training service providers and making sure that they are navigators to help in assisting clients throughout the service delivery points, and most important, tracking this individual while they embark on this difficult journey. So far, these are the two that we have online. with them as they come in.
Thank you, our online partner. The traditional medicine bit will come in our strategic cancer care strategy because it has been identified by the ministry but we didn't invite them to this meeting. We just wanted. So now we're inviting questions. We have 5 minutes from now and then we go to Beatrice. Yeah.
Okay. Good afternoon, everyone. I'm adding to the navigation conversation because it keeps coming up. So my name is Nana Chan Santi. I'm a 10-year survivor of breast cancer. And I say if anyone must have it, they must have what I had, because everything that we've talked about that informs a successful outcome is what I had. Early detection, access to navigation, everything that should have happened. We all know that's not necessarily the case in Ghana. So what we are doing, I founded Embrace Society, so I'm the founder. We are currently implementing a navigation. Prof. Mary talked about country-specific, culturally specific. So we ran it the first time. We did a big project. We realized it wasn't sustainable. So currently we have navigators in all the 5 major hospitals, working in collaboration with Roche. Now I'm going to quickly tell you how navigation has worked even in this instance quickly. So recently we partnered collaboration with another NGO to do screening in Ofwase. A lady came, she'd been diagnosed for a year. She didn't have money. She went to a private institution, so she went back to her farm. She heard about screening, she came. So the question was, why didn't you go to Komfanoche? If you know Ofwase, it's about 2 hours away from Komfanoche. I said, I've just seen the building, so she didn't go for 1 year. Within the day, I was able to connect her to the nurse navigator. Within a week, she had access to treatment. We were able to collaborate with other people to make it work. And now she's instigated, she started treatment in radiotherapy. So these are low-hanging fruits. And collaboration is key. What is your strength? What is my weakness? How do we all come together to make it work? So the case for navigation could start now through all our collaborative.
Yeah. Thank you. Beatrice.
Thank you. Thank you so much. I want to first applaud the Minister of Health for making this day a possibility. And I thank God that we've all lived to see this day. Because what we are doing is for our country, for our people. And we should not let this be one of those, because we have a lot of policies lying down which are not working. Fortunately, we have Mahama Cares. Let's tap into it and let's make this work. Some of the things that we have as challenges are the fact that in the country, out of the 16 regions, 8 regions do not have a single mammograph machine. Some teaching hospitals do not have mammograph machines. So what do you expect the woman to do, even for diagnostic purposes? We've been working for 23 years in the community, so we know what is happening. Let's make sure that we bring organizations together. We don't let it be based only in the ministry. Let's get the Ghana Health Service. Let's get civil society. Let's get people who are right in the community, opinion leaders, our chiefs, our queen mothers. They all have roles to play before we go to our sponsors, because they will be doing what we ask them to do. So let's get it right and get the right sponsorship to move this country forward. Thank you.
How many minutes do you have?
A couple.
Okay.
Thank you very much. So I want to also find out and also say that, to add that we need to also collaborate with the Christian organization.
the imams. I am coming from a region whereby religion and culture has mixed together. And so patriarchy system is what works. So even with the Mahama care, if a woman is diagnosed with cancer, the head of the family, not even the husband, the head of the family must say, go to hospital before they will go. So to get to where we want to get to in 2030, we need to involve these people, whereby they can speak to them. See, cancer is just like malaria. If you get malaria, you don't take malaria treatment, you can die within 2 weeks. So cancer has come to stay. Let's embrace it, and also let's encourage people to come. There are patients that were having support, just as Auntie Nana said, with the pilot patient navigation. At the point they stopped coming because the husband said the wife should stop coming. And that woman passed on with all the resources she was getting. So we need to involve them. Thank you.
Dr. Moko, go. Oh, okay.
Yes, thank you. And I'm just trying to add to what the lady said in terms of incorporating our traditional leaders as well as our religious leaders. I think, I don't know the statistics, but most of the people that come to us at first consultation would or may have gone to a traditional leader or to a pharmacy or to the church before they get to us. So we cannot have a comprehensive conversation without involving them. There's a lot of churches now treating cancer out there, and the pastor is telling them not to come to medical attention. So if we look at it as a medical problem only, we will miss that whole segment of people who are at the churches today or in the church camps today getting treatment for cancers and other things. So hopefully in the next National Cancer Forum, we should invite all of them so that we are talking about cancer, Ghana cancer care in a comprehensive way. Also, let's not forget the pharmacies. Most people will go to a pharmacy and buy medicine, or the off-counter drug sellers to buy medicine before they even come to us. So perhaps that is where the delay is. It's in the church, it's in the off-counter medicine seller, and it is in the medicine man, and that is what is bringing them late to us. It's after all those have failed is when they actually come to us. And even sometimes when they come to us and they are not hearing the right information, they go back there. And that is why we are losing them to some of these measures that we've put in place, and also that they come and they go and we are missing them in to follow up. Thank you.
Let's hear from the regional directors. Dr. Otu Amoko, dear.
Thank you, Chair. So my name is Dr. John Eko Otu. I'm the Regional Director of Health Service for the Savannah region. And for the records, I want to say that I've lost 50% of my parents and parent-in-laws to cancers, and the remaining 50% are fighting for their lives due to cancers. And again, as a firstborn and only doctor in my immediate family, I've depleted almost all my accounts because of managing cancer parents. But as a regional director sitting here, I've been trying to, the question I'm asking myself is what are the must-dos I'm taking from here? And I feel the passion of all people, players in the cancer environment, especially the partners, in the many things we are doing to help cancer management. But the question I'm asking myself is, looking at my region, and even my parents who are living in Accra and Kumasi, what we've gone through, I feel if we don't take time, this will be another talk shop. I just want to say that I think we need to be intentional, one, and help build systems. We already have those systems. I'm looking at my region, from the chiefs to the regional level. We know that we have a beautiful primary health care system in place, at least in the sub-region, we are one of the best. How are we strengthening the health system so that all the many things that we are talking about, we can speed up our progress? We've talked of human resource. I mean, the number of specialists that we need, the teaching hospitals even don't have them. When are we going to train all the number of specialists that we need? Yes, we need to. But whilst doing that, how can we strengthen the primary healthcare such that right from the chips, we can take advantage of what we have and help with the detection and referral system? The district hospitals, equipment, what's the basic that we can put in place so that it will help with the detection and getting to where the treatment is? So I just want to say that let's strengthen the health system that we are running. There are a lot of challenges that if I say I'm looking at my Savannah region. So please, let's leave here with some clear actions. I'm still, as a regional director, asking myself, what am I going to do living here? Thank you.
Dr. Oti, you know, in my introduction, remember I said structure, system, strategies. Structure, system, strategies. Okay? The question that I've been asking, even though I didn't bring the World Health Systems, the Ministry of Health, they are picking it. So if I were to be in your region, my takeaway from here is I will try and attract maybe visiting consultant to my region so that patients traveling all the way from Savannah to Accra, Kumasi, we will also set that system so that people will not travel far. And the question will be how you can achieve that. That will be resources. So that's what we need from you. Now, Dr. Amokodie.
I would like to thank the panelists for their delivery. But I think the Minister of Health, the Deputy Minister of Health, took the wind out of my sail. So, and with Echo Otu also coming in, I don't have much to say. All that I want to say is that we should be very practical on the ground. We should use the staff we have on the ground to achieve what we want. Coming out as an eye specialist, I didn't have anybody on the ground to start the DOMA project. I think, Doc, you know about it. The DOMA project, I didn't have anything. I trained ward assistants to recognize eye cases, to be able to really assist me in surgeries, to be able to take care of ophthalmic instruments, to be able to mount the operating microscope. Slowly, I trained them. Started with 6. Eventually, I ended up with 2 who were very good. 2 were untrainable, yes. So, so you see, we are behaving and we are going about it as if it is so big a deal. It's not a big deal. We should be just practical. We should get the what do we call it, the cow by the horn or the bull by the horn, and then we should run. And when we do that, we will move the mountains.
Okay.
Thank you very much.
Thank you very much. I think. Well, how many more minutes?
So maybe we can take the 3 hands up because we can't take Monsignor out.
No, I mean,
oh my God!
I don't want to go beyond the time. So,
all right, so I have permission to do maximum 4 minutes. So if people can keep their submissions to less than 30 seconds, that would be great. So over to you.
So now.
Prof. Sorry.
Dr. Otu, what will you do from here in terms of your structure, your systems, and maybe you can use Savannah as a case study? What are you intentionally going to do from here?
So, one of the things.
Whatever you say, we want to be intentional about it, not just.
So I'll just tell you one. One of the biggest challenges in Savannah region is doctors. So currently, just before coming here, I've drafted a plan for my minister to engage the 7 MPs who I think they are resourced to and something incentive to help us attract doctors. I'll give one instance, the Bupe Hospital, which is on the highway. Currently, there's only one, the medical superintendent, who is there. Can you imagine if there's an accident on that road? So getting doctors to my region is an issue. The last time they opened the portals 2 times, no doctor picked Savannah region. So again, this is just one thing, plus many others.
Let's listen to the Honorable Minister, please.
Like we have already discussed earlier, it's so siloed. Doctor is here, nobody knows that is here. So I'm trying to put the diaspora together so that if the request comes that we need a nephrologist, some of them will even come for free and do a 2-week rotation and go back. So let's look at a model like that so that the regional directors can request certain specialists, and me too, I can get to the ground and look for them around the world and see if they can come for 1 week, 2 weeks. And while they are here, it's not just doing the work, but to at least train 1 or 2 people in that specific thing that they're coming to do. So I'm thinking something like that coming from the ministry.
Seconds.
Thank you very much for the opportunity, Chair. My name is Dr. Afre from the Bono region. I want to touch quickly on this. For more than what the presenters have given us, and since morning from WHO's presentation and all the others, I've picked a few things here. One is the awareness creation and prevention. I'm very happy that cancer is now becoming the talk of the day. We have an MOH TV. Anytime I turn on, I go to social media or anywhere, I find the police TV is always all over the place, teaching us how to be on the road and everything. What happened to our MOH TV? That should rather educate people more. I think it was launched in February 2022, and since then, there's nothing. So if we can get some of these very important messages on our own MOH TV, I think it could dispel the myths that people have about it. The second thing I'll talk about is what is killing people with cancer is, I think, not the cancer itself, but the stigma and the trauma and the poverty and everything that goes with it. So what I'm pleading for is if the mental health team can help, because they need more psychosocial support than even the chemo. Because the moment they get to know they have cancer, then everything starts going at a rapid deceleration rate. So let's look for some psychosocial support to complement the palliative that Winifred is doing and the technical things that our able panelists are doing. Thank you very much.
Monsignor.
I am a Catholic priest, Monsignor Alex Bobby Benson. I've been listening to all that is going on this morning. Unfortunately, I'm not in the area of cancer. I take care of HIV persons for over 20 years. And I must say, I'm not boasting, but my intervention has been very effective. They listen to me more than they listen to the doctor because of the way I journey with them. Palliative care is not end-of-life issue. It's everyday issue. Right from the beginning, when the patient comes to the OPD, the doctor listens and says, go to the chaplain. The chaplain will have to counsel for the person to do the HIV test, the pre-counseling and the post-counseling. How to break the news to the person that you're HIV positive is not easy, but I have to journey with the person. My field is I train chaplains. So I want to say that whatever medical intervention we are doing, we shouldn't exclude the spiritual care. The palliative care is very important, and every step of it, if we take it serious, we'll get very good end results. Thank you.
Thank you very much.
So, last one. Their hands have been up for last one, and then we go for lunch.
Thank
Thank you very much. We are yearning for lunch. 30 seconds. So, we still wouldn't get the complement of all the disciplines needed to manage cancer in the country in every hospital. I think one of the easiest way to bridge the gap is to ensure that besides the comprehensive cancer treatment centers in Accra and Kumasi, the other centers can make use of telemedicine devices by joining the MDT team in the areas where they have it. And this is very simple. I don't think there's any hospital in Ghana which cannot afford a television and then data. We need to make use of that, at least to bridge the human resource gap until such a time that we are able to put proper human beings there. It's the same thing, because you may have a surgeon in a certain hospital who will be very good with the surgery on the breast, for instance, but other things cannot be done. You make use of the pathologists at the tumor board, radiologists at the tumor board, and it can go on. The second one, we have 5 documents in Ghana. Some of us here were put together in Akropong somewhere and came up with national cancer treatment guidelines. And as we speak, I don't know where they are. So from the CHIP compound to the teaching hospitals, we spelled out all the resource personnel there and define what they should do and when they should refer. As we speak, I hear there's going to be a review of the document and other things. So I think one of the things that we need to do as a country is to be practical. We do these things, and then they remain on the shelves. And I remember one of the agencies funded this thing. The copy that I took to my facility got stolen. So please, let us make use of the national treatment guidelines to give quality treatment and to be on the same wavelength. Thank you.
Okay, I think let's clap for our panelists. You know, in all these discussions, I was expecting one of us to ask about wellness. No, non-communicable diseases are such that by the time you feel something in the body, it's advanced. So the wellness thing that the ministry, Ghana Health Service started, and I call it, personally, I call it like everybody should have a health passport. That every year, when we are going to 2026, have you gone for your BP check, your blood sugar check? Have you gone to check yourself? Because that's the only thing that will make us more health literate. Health illiteracy is also killing us. So this morning, our panel, the focus of our discussion have been how to decentralize services. And one takeaway, the teaching hospitals are talking more about maybe artery services, training more people. Ghana Health Service is talking about attracting people to the peripheral areas. The partners are willing also to support. The palliative care people are talking about how to decentralize. So Ministry of Health, and then patient navigation has also become a hot topic. So Ministry of Health, I think these are things that you need to harvest when you are going to develop your national cancer care strategy. We know which one to bring forward. But ladies and gentlemen, I think there are certain things we can do. There are certain things we can do. The excuses are too much. One time I was making an excuse when I was moving from Kolebu to Komfo-Anokye. I don't have pathology, I don't have this, I don't have this. Government had to do this. But assuming government has established all this and we don't have the human resource, those things will still lie fallow. So wherever you are, you can do a little to change cancer care in Ghana. So let's live here and pick some of these things. We have our development partners. Let's network with them. We have people from teaching hospital. Let's network with them. Regional directors, talk to the specialists that I want you to visit my place once a quarter and build that system that you want. So on that note, I want to thank you for, for your attention. Thank you very much.
Thank you so very much, and thank you very much, panelists. So I think we've earned a little bit of time to go and refuel. House lunch. Please